Good evening, Dr. Debashish sir. Dr. Ravindra sir, good evening.
Good evening.
Hello, Dr. Paneerselvam. Hello, Dr. Debashish.
I'm
Hello,
your
Dr.
live.
Ravindra.
Good evening. Good evening.
Good evening to all of you.
Okay. Shall I start, Mr. Shari?
Yes, ma'am.
Yeah.
Yes.
Very good evening to one and all of you. And we look forward to another great ARC webinar, and this time on SICS. And for the next 2.5 hours, I'm sure we are going to be gripped to our chairs with lots of learning coming along the way. And needless to say, it goes without saying that SICS is a most popular and a very versatile mode of cataract surgery, and is an answer to all situations, routine and complicated. And this is what we are going to drive home today in the next couple of hours or more. And we are really looking forward to the great set of expert panel giving in their inputs. And we have with us Dr. Debashish Bhattacharya, who's the founder chairman of Disha Eye Hospitals and a very leading cataract surgeon. And I'm sure he's going to give us pearls of wisdom related to SICS and the different scenarios. We have with us Dr. M.S. Ravindra, who's again the chairman and medical director of Karthik Netralaya, and of course, a founder director of Jyoti LASIK Vision Center. And more importantly, another very prolific surgeon we are proud to have amidst us. Joining us soon would be Dr. Saurabh Patwardhan, who's the director of Nandadeep Eye Hospital, Sangli, and is also the director of the very popular fellowship program which they have at their place. And we look forward to his great inputs. We have joining us soon Dr. Deepak Megur, who's a consultant and director of Megur Eye Care Center at Bidar, and specializes in complex cataract surgeries. And I'm sure he is going to have tons of pearls to share with us. Joining us for a short time, because Dr. Jagannath Goramani has some other personal responsibilities. He's the chairman of the International Society of Manual Small Incision Cataract Surgery, and also a specialist in customized incision cataract surgery, and is a consultant at Surya Netralaya at Vasi, New Mumbai. And of course, with us is another big proponent of SICS surgery and a very national figure we are all proud of, is Dr. Amulya Sahu, who's a practicing ophthalmologist at Mumbai and is the managing and medical director of Kamal Netralaya Private Limited. And this has 3 hospitals situated in different parts of Mumbai. And more importantly, he is another, not just a proponent of this concept of SICS, but he's also the founder leader of this International Manual Small Incision Cataract Surgery Society. And we look forward to having him with us the next 2.5 hours to tell us where we are going right and where we are going wrong. Moderating with me is Dr. Satyajit Sinha, who is the chairman and medical director of ABI Institute, Patna, and again a very popular cataract and glaucoma surgeon, and also who's standing as who's the member ARC East for the 2nd term, a very popular national figure and very warmly liked by one and all of our country. And without wasting any time, I hope a wonderful set of speakers have joined in. Has Dr. Divya joined in? Divya has not joined in yet. Dr. Satyajit, Divya has not joined in yet, I think, right? So, shall we
No,
go?
ma'am, she has not yet joined.
We'll go on to Dr. Dev Prasad.
Dev Prasad, can you call Divya Nagha? It will be a big help. We shall go on to Dr. Deva Prasad Gopal, who is a senior consultant in cataract and refractive surgery from Modi Eye Hospital and Prasad Eye Care Center, Bangalore, and is involved in surgical training of students and has a number of presentations to be proud of at the state and national levels. And he is going to talk on a quintessential topic, choice of anesthesia in small incision cataract surgery, and let us hear from him.
Am I audible? Am I audible?
Yes, yes.
Yeah. Good evening, ma'am. Good evening, ma'am. I would like to share my screen right now.
Yeah.
Yeah, at the outset, I would like to thank the All India Ophthalmic Society and the Scientific Committee for giving me an opportunity to present in front of all the big stalwarts in SICS. Today's my topic is about the choice of anesthesia, which is a very important step in SICS. The history goes back to the ether, which was synthesized in 1540 by the Cordes, but no longer now it is used because it has got a lot of side effects. So chloroform was formed in 1853 by Dr. John Snow. Then endotracheal tube was a very good invention in 1878, followed by thiopental in 1934. So what is an ideal anesthesia? An ideal anesthesia should make the surgery painless, and it should be easy to administer, safe. Akinesia should be there, and it should be comforting to the patient, and the recovery should be smooth. So broadly, anesthesia can be classified into local, regional, and general. We are interested only in the local anesthesia, where we do only topical and infiltration anesthesia. So types of anesthesia, infiltration anesthesia, there are basically three types: retrobulbar, peribulbar, your subterraneous block. Then the most popular topical, along with intracameral and general anesthesia. Coming to general anesthesia, this is reserved for especially for patients with Parkinsonism, congenital cataract, deaf and mute patients, patients who are mentally retarded, psychiatric treatment patients, and some patients who request for general anesthesia in particular. So phases of general anesthesia includes induction, maintenance, and recovery. So this is done by the anesthetist. So the triad of general anesthesia involves hypnosis, analgesia, and relaxation of the muscles. That is muscle relaxation. So what are the hypnotic drugs which we use? The gold standard is a thiopentone, followed by propofol, etomidate, benzodiazepines, and ketamine. Inhalation anesthetics, the most common is the nitrous oxide, followed by isoflurane, sevoflurane, desflurane, and allothane. Analgesia is also been given by giving non-steroidal anti-inflammatory drugs. The gold standard is aspirin, followed by ibuprofen, diclofenac, and COX-2 inhibitors. So also by opiates, in which morphine plays a very important role, followed by fentanyl and remifentanil, which are ultra short acting. So muscle relaxants, generally, they aid in intubation, they help the surgeon, and it also helps if the surgery is of long duration, and it reduces the maintenance dose of anesthetic agents. So the blocks are many types actually, depending on which nerve you want to block, like the supratrochlear, zygomaticofacial block, or infraorbital, which supplies a specific region. So first starting, it was widely followed anesthesia is the retrobulbar anesthesia, which was described in 1884 by Knapp. It blocks the ciliary nerves, second, third, and sixth cranial nerves. So it is given into the retroconal space around 3 to 4 ml. It blocks the cornea, uvea, and the conjunctiva, as well as it causes akinesia of the extraocular muscles. So it is not very much famous because it is bound with complications. Around 1 to 3% of complications has been reported in literature. The most common is retrobulbar hemorrhage, ocular perforation, especially in eye myopes and patients with staphylomas, subarachnoid or intramural injection, which is rare, postoperative ptosis, diplopia secondary to myotoxicity, cardiorespiratory distress, injury to optic nerve, and vascular retinal calculations are little rare. So peribulbar anesthesia is the most commonly given anesthesia. It is discovered in 1980 by David and Manda. It is given in the extraconal compartment, 2% lidocaine, 3 to 4 ml, coupled with bupivacaine, which is a long-acting anesthetic, around 0.5%. Usually it is mixed with hyaluronidase, which is 50 units per ml. It can be mixed with adrenaline, which is in the concentration of 1:1 lakh. The main drawback is congenital chemosis and rarely hyaluronic acid allergy. So another very good technique is a subtenon anesthesia, which is described by Stevens in 1992. It is injected into the peribulbar space beyond the equator, around 2 ml of 2% lidocaine. It is less painful, better akinesia. There is very small rise in IOP. The effect lasts for 60 to 90 minutes, and with 4 to 6 hours of postoperative analgesia. So the subtenons is given by a special type of cannula, which is angulated and is not bent at any degree. So the very commonly used is a topical anesthesia, which was reintroduced in 1982 by Finchman. There is no risk of ocular perforation, no injury, no sinus depression, and vision regains immediately. That is the one attractive factor which patients want. So there is another technique described called as no anesthesia by Dr. Amar Agarwal in 1998. It goes with the concept saying that the peripheral and superior cornea is less sensitive than the central cornea. This is because of exposure to UV rays, but it is not gained popularity because it causes increased stress for the surgeon to give best to the patient. So it was now again modified by Carmona, known as cryoanalgesia, in which all the solutions are cooled to 4 degrees Celsius except the povidone drops. So eye mask of cold gel is placed over the eye for 10 minutes and then the surgery is done. Topical anesthesia is the commonly performed surgery. It blocks the long and short ciliary nerves, mesociliary nerves, and coupled with intracameral 1+1% preservative-free Lidocaine. The surgeon's requirements are he should be consistent in surgical outcomes and he should be confident in his surgical skills. Patient selection, you should always avoid anxious patients, avoid those who opt for topical because they're scared of blocks, uncooperative patients, high risk category like the severe bells, respiratory and cardiac, you need to have an anesthetic backup. So advantages is you can operate on a normally pressurized, there's no chances of hypotonia or a tight globe due to RVH. It can maintain coaxiality of the eyes, peer pressure to stay in the race because everybody wants no stitchless, painless surgery. And if the patient is requesting for a topical, you need to give him a top benefit. Conclusion. So type of anesthesia depends on the surgeon, okay, and it depends on the grade of cataract. If it's a very hard cataract, better to block the patient. And if the size of the pupil is little small, if you need to use a pupil expander, then better to get the better the eye to be blocked. And patient cooperation is at most needed. Subcutaneous or topical with intracameral lidocaine works well in all cases. So I'll just 2 minutes. I'll just show you this entire surgery is done at a topical. Intracameral lidocaine is injected, then the stained with trypan blue dye, and it is washed with saline solution, and then AC is formed with viscoelastic surgery. The main idea is to make the AC deep. The AC should never collapse. If it collapses, the patient winces in pain. So always maintain the anterior chamber with a copious amount of viscoelastic. It would be better to use a dispersive viscoelastic agent. Once the rhexis is done, then the conjunctiva, has already been anesthetized by 2 to 3 drops of proparacaine in the beginning of the surgery. So once that is done, congenital peritoneum is done, and then you, as you know, the sclera is little insensitive. You can take a incision of 5 to 5.5 millimeter and then make a sclerocorneal tunnel. Once that is done, then you can enter it with a keratome. Once the keratome we enter, then hydrodissection is done and the nucleus is just delivered into the anterior chamber. Now the time is to remove the nucleus, but you need to inject a lot of visco, protect the corneal endothelium, don't let the AC collapse, and remove the nucleus in one go. And then the anterior chamber is washed with all the remaining epinuclear material and cortex. And then you can actually ask the patient to keep looking at the light. As you can see, this entire procedure is done under topical. The patient's eyeball is not retrieved because you are constantly telling the patient to focus on the light. Yeah, I'm done with it. And after this thing, you can just inject, you can put viscoelastic at the end of the surgery and place an intraocular lens. So intraocular lens also can be placed very comfortably inside the bag, and it can be dialed inside the bag, and whatever remaining cortex can be washed off in the end. So, and this entire thing can be done at a topical. So topical SICS is the present, and it's going to the future, and it gives results as good as phaco and as better than phaco. Thanks a lot, and thanks for the opportunity. For attention.
Thank you very much, Doctor. That was a wonderful, very crisp talk and covered everything. Actually, I realized that I do not have effective questions to address because you seem to have covered it all. But having said that, I would want our experts to comment on this. Dr. Ravindra, Dr. Sahu, any one of you, Dr. Deepak Megor, when do you think a surgeon in SICS would need to look at going on to topical intracameral anesthesia? Do you think that's mandated, keeping in view that there is more conjunctival handling and all that? Doctor?
Can I answer this?
Yes, Doctor.
Yeah. See, as far as handling is concerned, the conjunctiva is the tissue which can be easily anesthetized by topical medications. And I mean, it's short acting. It doesn't act for a long time, but you can always add on additional drops to clear it up. I think conjunctival handling is not a big issue as far as anesthesia is concerned. The main issue is the ciliary body, which is painful. Iris and attached to the ciliary body. Whenever you handle the iris and pull the ciliary body or stretch the ciliary body, that's painful. Cornea and conjunctiva being the surface tissues, I think it's not a big issue in considering it. I personally would recommend all SICS persons, surgeons over a period of time to switch out to topical, which is probably the most elegant way of doing surgery. Not that injections are avoided. That's one major reason, and that there are a lot of complications that are described because of injection anesthesia. That's avoided. But of course, you have an alternative of subtenon injection, which is prick-free and which is as safe as topical. But then topical means that you're handling tissues very gently, and that's the biggest plus point that I would insist on. I would suggest everybody to switch over to topical. It's very easy, as Dr. Dev Prasad told. It's very easy to switch over. There are a couple of steps that you'll have to look at, and it's a possibility.
Yes, and as far as yes,
yeah,
yes,
I think before a beginner switches over to topical, must make sure that he gets rid of the bridal suture. There is a practice of using the bridal suture as a fixation, but I think that in topical anesthesia would be a challenge, and he should be predictably good in his surgery, completing a surgery in 5, 7, 10 minutes. As Ravindra pointed out, I cannot agree more. In fact, we must now consider, because SICS is also for the masses, a surgery for the masses, that the rate of infection, endophthalmitis, is probably less than globe perforations. So, and globe perforation is such a dreaded complication that you really can't do anything about it. So, yes, topical is the way, and you can always top it up with subtenon if required with an uncooperative.
Supposing you are not doing topical yet, now we know retrobulbar is on its way out. Dr. Paneer Selvam, would you want to answer this? What would your take be on either doing peribulbar or moving on to subtenons? You have to unmute yourself. Yes, doctor.
We are more comfortable with peribulbar in our institute. We tried the subtenons, but the system has to be adjusted, and the results are the same. So we are continuing with the peribulbar. We don't find any issues with that.
Dr. Deepak?
The issue with the injection anesthesia is, the subtenon scores over other the injections because it's very safer. The safety parameter is tremendous. You're using just a blunt cannula. So even if the first year resident is also giving it, there's absolutely no chance of any globe perforation or any complication. So that should be the single most important reason for us to switch on to subtenons, even when a first year resident does that. I think in the modern era, I don't really justify the use of needles for anesthesia.
Yes, I totally agree on that. And I'm sure places where large-scale surgeries are being done, I think the young PGs are giving, especially I'm sure in Arvind, that's the way it's happening, no? The subtenon, Dr. Revati? Yes.
Yes,
yeah.
Yes, subtenons only.
Yeah. Any other questions, Satyajit, you would want to ask, or shall we go on to our next speaker?
We can go on to the next speaker.
Yeah. So then we have Dr. Divya, who should have been our first speaker, but went missing. So we found her.
Sorry, madam. Had some connectivity issues.
Yeah. I'm just pulling her leg. She's a medical consultant, cornea and refractive surgery from Arvind Eye Care Systems, Chennai, and is a very versatile, very graceful surgeon. And I'm sure she's going to tell us a lot, which are still gray areas on the basics and astigmatism management in the manual small incision tunnel. So on to you, Dr. Divya.
Thank you, madam. Thank you for the kind words. I'm once again very sorry about the delay. I hope my slides are visible.
Yeah.
Okay. So I'll be talking about the basics and the astigmatism management in small incision cataract surgery and how do we construct tunnels. So at the end of the surgery, we all wish that we give patients 6/6 vision, and the patient also, looks for 6/6 vision post-op day 1. So with good tunnels, we can actually give very good outcomes even in small incision cataract surgeries. So as we all know, there is the regular astigmatism, irregular astigmatism, and the oblique astigmatism. The regular astigmatism and the principal meridians are perpendicular, and irregular when they are not perpendicular. So these are just the basics. So there is something called the pre-existing astigmatism, which can be recognized by using a good keratometry. And there is something called what the surgeon induces. And there are so many factors that contributes to how the surgeon can induce astigmatism in an otherwise normal eye. So pre-existing astigmatism, again, it would be wise to place the incision at a steeper meridian, which can be visualized with good keratometry findings. And again, the final astigmatic error largely depends on the preoperative astigmatism. So that should also be considered when placing your incision. And we can also modify the wound to make sure that we have a good astigmatism-free tunnel. So cautery, again, this is very, very important because we need a clear field when you have to do a good incision. So it's always good to retract the tenons well before applying cautery, and it is wise to use a wet field bipolar cautery rather than using a ball tip cautery or a unipolar cautery. And make sure you retract the subtenons area well. That's because when there is charring of the subtenons, what happens is there is going to be irregular astigmatism caused by the wound. When you make a wound, it's going to be ragged edges is going to be present, which is again going to interfere with your outcomes. So that is very important. And again, do not apply your cautery after you have done your tunnel. It should always be applied before the tunnel is created. The reason being, once you apply the cautery after the tunnel is created, you're definitely going to cause fish mouthing, and there is going to be, again, a wound gap there, which is going to affect the outcomes of your surgery. And applying too much of cautery in a random fashion over the sclera will again cause scleral shrinkage and can also lead to scleral necrosis. So again, incision characters, we need to decide on the location, the length, and how do we configure the wound. So this is very, very important. As already mentioned, it is good to place the incision at the steeper meridian. And when the incision is too close to the limbus, then again, we're going to induce more astigmatism. And the wound actually has the external and the internal configuration. So the external configuration, again, the size of the wound totally depends on the size of the nucleus that we're dealing with. So a large nucleus, say a grade 4 to 5 or a black cataract, will definitely need a larger incision. So the first diagram here depicts the smile incision, the straight incision, the inverted smile or the frown incision, and the chevron or the V incision. So there are two entities to any incision that we have to consider. One is called the arc length and the other one is the chord length. So the arc length is nothing but it's the line that traverses throughout the incision. So this is the arc length. Whereas the chord length is the point of initiation and the distance between the point of initiation and the point where it ends. So when the chord length is going to be less, then your astigmatism is again going to be less. So that's why the frown incision or the inverted chevron or the V incision gives us less astigmatism, and this is the most preferred incisions. And the other beauty of these incisions is that the ends of the incision is far away from the limbus, thereby creating a better tunnel. So again, internal configuration, it's good to have a 3-planar incision. So the first plane, which is created using the first plane which is created using the crescent blade, it is created in the sclera, and then you dip using a keratome. That's the second plane. And then when you enter into the cornea, that's the third plane. So when you create a 3-planar incision, it's going to give you a good wound position. And again, when the entry into the cornea should be not more than 0.5 millimeters. So that's something that we have to take care of. Too much into the cornea is definitely going to cause a lot of astigmatism. And again, there are high chances of creating a Descemet's detachment as well. So again, the length of the wound is very important. So astigmatism is directly related to the cube of the length, and it is inversely related to the distance from the limbus. So that's why the more posterior your incision, the better it is. However, too posterior will cause difficulty in handling your instruments. So
He's saying you have a minute to go. Yeah.
Oh, yeah. Okay. So again, configuration of both external and internal configuration needs to be considered. There's something called the quartz tunnel, which is an imaginary tunnel. There is nothing but two imaginary lines that moves away from the limbal area outwards. So when your incision is placed within the tunnel, then you have good astigmatism control. So this, when you see the straight, the first picture depicts a tunnel which is too small for the nucleus to be delivered. Whereas here, when you have the smile, you see that it is very difficult for it falls outside the quartz funnel, and here thereby causing more astigmatism. Whereas the straight and the chevron of the frown incision will fall within the funnel, which is going to give you good outcomes. So again, suture, when you apply, we very rarely apply sutures for any SICS case, but when it is done, you have to make sure that you have adequate length, the depth is good. So length, again, when your sutures are equally placed, same size and same distance, then you're not going to induce any astigmatism. Whereas when your length is going to be more than the distance between the two sutures, you're going to induce visceral astigmatism. And when your distance between the two sutures is going to be widely placed, then you're definitely going to induce against the rule astigmatism. So again, tight sutures, two tight sutures will cause increase in visceral astigmatism, and a loose suture will not serve the purpose. So again, it's not going to help you at all. And again, the suture depth should be only about 90%. And as you see, when there will be indentations if you're going to have sutures that are not placed well. So again, only 90. You have to make sure that your sutures are about 90% in depth, and two superficial sutures is definitely going to cut through the tissue, which will again cause increase in against the rule astigmatism, and it's definitely not going to give us a good tunnel. So again, you have to make, if you're applying more than one suture, then it has to be radial sutures. Too tight, you will see radial folds on the cornea, which needs to be avoided. So post cataract surgery, if at all there is any astigmatism, it would be ideal to do a suture removal probably after 3 months of surgery. Again, spectacles, contact lens. We don't do LASIK, but there are a lot of surgeons who do LASIK for patients with astigmatism post cataract surgery. So, so spectacles usually we dispense after 1 month of the surgery, and the suture removal is usually done 3 months post surgery. Thank you very much.
Thank you, Divya. That was a wonderful talk. All the essentials were there in your talk, and really look forward to you involving yourself in the questions which I'm going to ask. We do see some surgeons making a sclerocorneal tunnel directly with the keratome. Maybe they are experts in it, but is there a pros and a cons to it? Divya, can you answer that?
Definitely, any beginner, it's not advisable at all, madam. It's always better to use a crescent to do it, because it's more controlled and the edges are not as sharp as what you would see in a keratome. So it's kind of curved, so you get a good tunnel. I would any day prefer doing a crescent and using a crescent and using the keratome.
But supposing you've had a premature entry and the valve effect is lost and there's going to be iris prolapse, how would you manage these wounds?
So in case, I mean, if you are having a buttonhole in the or premature entry in the beginning, it's always better to suture that site and move away from that site and create a tunnel at another site. That would be ideal.
Dr. Ravindra, I wanted to ask you about astigmatism management. How do you compare superior to a temporal tunnel? And if it is going to be a temporal tunnel, would you need to vary your shape? Like, would you say whether to do a frown or a straight if it's a temporal tunnel? How would you plan choosing these?
Yeah, I think the basic configuration of the cornea before surgery, it's with the rule or against the rule. With the rule, the steep meridian is vertical. You start, I think the best is to mark the axis just like you implant a toric lens for beginners. mark it exactly 180 or whatever custom you have in your hospital, and then consider this as a astigmatic cornea, and which can be corrected by your surgery. If it is with the rule, imagine the steep axis at 80 degrees, you start the surgery at 80 degrees. If it is at 110, you start it at 110, 105, depending upon that. If it's against the rule, most of the corneas are against the rule. As you know, 80-90% are against the rule. So straight away you identify the steep meridian on the horizontal axis and start on the temporal side. Either when you do on the superior side, the bridal suture is necessary for many patients, unless especially if you give a block, you can't ask the patient to look down. So you need to have a bridal suture. That's one big advantage of selecting the temporal. And then the prevalence of against the rule astigmatism in that age group is very, very helpful. Consider about the incision, whether straight, frown. See, that's important only if you're going to do very close to the limbus. But if you're anyway starting 1.5 millimeter behind the limbus, and then if your incision is not too big, imagine you're not going to do 8, 9, 10 millimeter incision. In my hands, my experience, the frown or smile or straight has not given much difference. So it's convenient for me to do a straight incision. I'll switch over from frown to straight long time ago. And we do preoperative and postoperative care reading. That's what I would recommend everybody, to do a preoperative care reading and post-op care reading at the end of 1 month, and then do the vector analysis. Just like one cylinder before, one cylinder after, doesn't make a sense. The axis is different. So you'll have to go back to the formulas, vector analysis, then you'll be able to analyze your results much better. It's nice to have a sheet wherein you have given input data, like what is the size of the incision, how far away is from the limbus, what's the length of the incision, is it frown, and have you extended it laterally, did you stretch the wound during surgery, how much you cauterized, and all that you put it as analytic data inputs, and they find out your results. I think each surgeon has a signature, and his astigmatism varies depending upon the type of surgery he's going to do.
Yes, Dr. Sahu, yes.
Yeah, because see, bridal suture, as Devasi said, people should not be encouraged to use it. We are totally no. So maybe it's not good. And we can do all kind of surgery without bridal suture. So that should not be encouraged for the younger students. Now, next thing is that temporary, you were asked temporary incision, there is no need for a frown incision there because the fibers are arranged in a different way. So straight incision is the thing, because that will not reduce much of astigmatism, but straight incision is the thing that has to be done. Right. These 2 points I wanted to do. Bridal suture, we are discouraging totally.
Okay, then when would you tell a beginner surgeon to put a suture to his sclerocorneal tunnel, Dr. Deepak? Yes.
If he's not sure about the valvular effect, sometimes the surgeon creates, and if he's not certain that the valve is functioning, then it is better to suture the wound with one single 10 nylon radial suture. Or in this case where he's used a very large superior incision, it's going to induce significant amount of astigmatism. To counter the astigmatism, he can always use a single stitch, which is going to counteract by inducing withdrawal astigmatism. So these are the two scenarios where I would recommend a beginner surgeon to use a suture.
And also, if he has placed it opposite to the steep axis, then also he could.
Yeah, usually most of the patients are having against the rule. Yeah. And if you place a withdrawal astigmatism, it's going to worsen. So in those situations, I think a single radial suture is going to counteract a little bit better.
Yeah. So when you make this tunnel, you would start by creating a groove probably. So if you do that, would you advise a 15 number blade for that, or would you advise having a guarded knife for that?
I think nowadays we have the luxury of having the depth defined guarded blades. But we all learned with just the regular Bard Parker blade. But if you can afford one, definitely you can go with the one with many half thickness scleral pre-grooved blade are there. Those would be ideal if you can afford one. But otherwise, you can just learn. With a few cases, you get the hang of it.
Yes. Thank you very much. Anything else to ask, Dr. Anand?
Chitra,
Yes. Yes, Dr. Devashish.
About the incision.
Yes.
I think for beginners, what we have usually observed that the eye is curved like a globe, right? And so when you start the incision, you are a little shy, whether you use a Bart worker or you use the splitter. So usually the initial part of the incision is a little shallow, and the middle part becomes deeper. And again, in the periphery, it becomes shallow. So essentially, if you see that this ultimately guides the scleral tunnel. So you have a buttonhole usually in the periphery, and as you were saying, the premature entries would occur in the center. So I think consciously, a beginner has to be, he has to be taught or brought into their head that this is a common thing that you are on, and you can be safe. And let us understand one more thing, that SICS surgery has another big thing, because it can correct significant astigmatism. You can take up an eye with, say, 1.5 cylinder, 2 cylinder. With an OCCI, I think it can give you a correction up to 2 cylinder. So essentially, if a patient cannot afford toric lenses, you might as well choose the patient to give him a little more tissue dissection, even in a softer cataract, and give him the benefit of post-operative, no astigmatism over phacoemulsification. So SICS is a good surgery even to correct astigmatism.
Yeah, but I think for a surgeon who's doing it very in a titrated manner, maybe you could compare with torics, but otherwise I would keep
very
in mind
grossly
that the wound
speaking,
drift which can occur in large incisions.
Yes, I mean, if you are doing it over and over again, you can develop your own nomograms like Boromani has done. Yes. So he can correct predictably astigmatism, then he can know what would be the residual astigmatism in his surgery. So
yes. Dr. Saurabh, what about the wound drift which can occur in these large incisions? We know that, but anything newer which has happened which supports SICS more?
Yeah, I think that is the major concern, because most of us, of course, in phaco also, we see very short-term results. Yes. And when we see this patient after 2-3 years coming back, and we have corneal remodeling, and we never know what will be the final effect. Yes. Of course, I think there are many surgeons who have done probably long-term studies. I think they have operated for years together, so they will be in a better position to tell. Yeah. And it's very subjective, because surgeon to surgeon, I think skill levels are quite different. But what I have seen, whenever superior incision is taken, there is definitely a drift over a period of time. And sometimes it is beneficial also, because this astigmatism may add to some near vision, uncorrected near vision, as is proposed. Yes. But I think that, for me at least, remains an unpredictable area of SICS.
Yes. Thank you very much. That was a wonderful discussion. We shall now go on to our next speaker, Dr. Mallika Arjunan, who is a senior consultant cataract, cornea and refractive surgery from Shankara Eye Hospital, Shimoga. Again, he is a surgeon of great skills with a lot of presence in the state and national conferences. He is a member scientific committee of Karnataka State Ophthalmic Society and the General Secretary of Malanad Ophthalmologist Association. And he is going to talk to us on something very relevant, nuclear fracture and its relevance. On to you, Doctor.
Dr. Chitra, can I just add one point here?
Yes, sure. No, very important astigmatism. Yes.
About the tunnels. I think Dr. Divya beautifully presented her submission. But one thing is, what I would recommend is, if there is a premature entry or premature exit, then you can actually, instead of going to another place, you can start in the same place again, go up or below the initial tunnel, and then you can complete it in the same way. So that's what I just wanted to submit.
Yes, and I'm very sorry, Dr. Subudhi, you should have been the third speaker. Is it all right? I just slipped my mind while I was involved. You will be the fourth speaker. It's all right, Dr. Subudhi?
Okay, no problem.
You will be the next speaker. Yes. So on to you, Dr. Mallika Arjunan.
Am I audible?
Yes.
At the outset, I would like to thank Chairman ARC, AIOS, Dr. Chitra Madam, and all the members of ARC for this opportunity. I'll start with the technique of doing a nuclear fracture, and I have made with the intention of showing it to a beginners. See, this is just around the 4 millimeter peritomy, and I am marking with a 5 mm caliper and just a 5 millimeter mark there on the sclera, and a 5 millimeter scleral incision, straight one, and it is a temporal side. And there is no need to use a cautery also. It needs little bit experience, and you can stop using cautery also. And you make a tunnel at one side full, and this is what I do, and it is easier. And just you can dissect the scleral fiber and complete the tunnel. And also it is very important to extend at the inner side both sides, something like it is like a trapezoid side, because we are removing the nucleus fragments in a very small section, and it is better to do a extend at the periphery. And as usual, rexis, and it is little bit larger than your phaco rexis, and the extension of the tunnel. It's very important to extend the whole of the tunnel and not to cut at the posterior lip. So tunnel has to be like tunnel. It has a four walls and a gentle hydrodissection there. And it is always better to do a gentle hydrodissection and rotate the nucleus, because this is what I do, because the safety is better when you rotate the nucleus, because it has to come out of the bag. And if it is rotating, and easily it would come out of the bag, the nucleus. And now it is in the entry chamber. Put a viscoelastic, just it is a HPMC and no other viscoelastic put. And vectis, this is a modified vectis. It is maximum width is 3 mm, and dialer, the tip is straightened. And it has to be in the center. The victus has to be in the central. I'm using dialer. I'm not actually pressing it. Not only pressing it, I'm making a rotatory moment there, so that the nucleus will divide into two pieces. So remove the, you can take out the one piece first. And the remaining one half is, again, it is placed in the center, because the nucleus has to come through the tunnel. So it has to go, the direction of the pulling should be same as the direction of the tunnel. And you can then do the cortex wash. And the advantage of this is you can use a foldable IOL. So and the care should be taken not to press the posterior lip, so that it would be a closed chamber surgery. This is a one more surgery, because of I think a shortage of time. I will directly go to the nucleus fracture. See, hydrodissection has been done, and the nucleus is prolapsed into the interchamber. It is, again, I'm repeating, it is important to put the viscoelastic on the nucleus and below the nucleus before you do the fracture. Again, the modified vectis, and it's it has to be in the center. Otherwise, what happens if it is a periphery? When you press it, the one side of the nucleus will move up, and it might injure the endothelium. So if you are in the center, definitely it would not touch the endothelium, right? Even at the center or at the periphery. Again, the nucleus is one part of the nucleus is removed, and in the same way, the nucleus, the other part of the nucleus is brought in at the center, and it is taken out. So what are the other methods? These methods I'm not doing just for the completion sake. I'm talking about it. There is one more snare method where there is snare-like thing which you can engage the nucleus in the snare and crush it into 2 pieces or 4 pieces and make it out. And there is some persons are doing intra-tunnel fracture because I don't know because I don't do this procedure. I'm not going to talk about this. And what is the relevance? Because it's when you make a small section, it's a closed chamber surgery. So we all know the advantages of closed chamber surgery. There is less chances of the end-to-chamber fluctuation, less chances of the PCR and other problems, and there will be very less surgically induced astigmatism because of a small incision, and if you are doing at the temporal section. And when you have a PC rent or general dialysis, it is because of the closed chamber, it will be a very easy to manage doing the ventral vitrectomy and putting implanting the IOL would be helpful. And if you have noticed, there is no need to do any side port unless you have a very large subincisional cortex which is not coming. You can put a side port. And because of small peritomy, the closure of the wound is very faster, and patient can be rehabilitated very early. And this thing I'll put it to all the panels because India has so many cataracts, and there is a lot of backlog of cataract. At least for the beginner or who has learned surgery when he starts his practice, or whether he can just avoid buying phacoemulsification and start doing this phaco-fracture, and which gives as good results as phacoemulsification. This thought I would give open to all the panelists. And one more thing comes to our mind is whether the endothelium will be protected or not. See, these are all the picture of a post-operative taken immediately within 4 hours and within one day. See, you can see almost all patients are clear. If you learn this technique, the endothelial damage will be minimal or no endothelial damage. Thank you very much.
Thank you very much. Satyajit, would you want to take a question? Satyajit, are you there?
Yes, ma'am.
Yes. Yes.
My only issue was that when we are using this, we are bringing it into the anterior chamber.
Yes.
Would it not hurt the endothelium? And would it be more helpful using a thicker viscoelastic in these kind of surgeries rather than the regular HPMC? Would that help in protecting the endothelium?
Definitely that would come to everybody's mind because if you can use something like a viscoat or viscoat-like material which are available in India. At the beginning, you can use it, but once you become a little bit experienced, and you can use the HPMC only. You just HPMC, it will nicely coat the endothelium, and your endothelium can be clear. I mean, cornea can be clear later.
Dr. Deepak, when we talk about fracture technique, in the bag or versus AC fracture, anterior chamber. So what are the for and against on this? Can you unmute yourself?
I think both of them have got a distinct advantage versus in the anterior chamber fracture technique is extremely ideal for most situations, including where the zonules are weak and where the bag is compromised. However, when the corneal endothelium is slightly compromised, we're dealing with a lesser count cell. In those situations, maybe fracturing the nucleus in the anterior chamber might not be the best option. For me, if the bag is healthy and zonules are healthy, in the bag fracture is the most safest way to break this nucleus. That is my preferred method when I'm doing manual spontaneous cataract surgery. However, in cases where in Morgagnian cataract, where the zonules are weak, that time I don't want to meddle anything inside the bag. Just prolapse the nucleus out into the anterior chamber and then fracture it. Yes. So there are two distinct, advantages in each of the places. Thank you.
Now we know there are a loop or snare or bisectors being used. So either Dr. Ravindra or Debashish, one of you all could tell me which one is what you would suggest as the early steps for a surgeon, and what extra precaution to be taken when you're using a loop, when you would use it, when you would not use it?
Rahul sir wanted to make a point, but he is muted.
Yes, Dr. Sahu, we would like to hear your thoughts too.
What I saw that I have tried this method of dividing with the dialer, but I think it's a risky proposition, and because maybe in an experienced hand you can get away with some, but it is not the right way to divide the nucleus. The moment you put the rectus behind the lens, all viscoelastic comes out. And if you are having a high viscous there, totally the ball, it will come out. So what we are dividing the nucleus, continuously infusing this viscoelastic and then dividing, then the chamber is maintained. That point I wanted to add.
Yes.
Second thing, we are now dividing the nucleus in the bag. Megur is doing, I am doing, so many other people will be doing now. So there is no difficulty in dividing the nucleus in the bags. So snare, of course, is the Indian origin, so we can use it. There is no rule. There is no room for my loop and all sort of things. There is no need for that. Our loop, the snare is as good as that my loop. And now that we are dividing the nucleus in the bag, so there is no need for it. We can do it a 2 millimeter incision. I take out the nucleus. So FECO, I think we should have a comparative surgery.
Yes.
Yeah, let us have a comparison all India level with your initiative. Top surgeons, we will do side by side and evaluate the results afterwards. I think that a time has come for us to really think that the SICS has come of age, and it is absolutely, result is unbeatable. So I think you can take an initiative to call few surgeons and let them simultaneously operate, and let us compare results.
Just my doubt. See, when you compare the anti-chamber fracture and intra-bag fracture, the intra-bag fracture technique learning curve is a little bit more, and that is what I believe, because you have to be careful.
That is see, it requires a pretty experience. It should be very experienced to get into the bag and divide it there. Not for the beginners, but we are doing it now regularly. We are doing it. I saw this. Deepak is also doing a good job.
That's a take-home plan.
I'm doing all my cases in the
very
bag.
experienced,
Most of the cases,
not for the beginners.
80 to 90% cases I'm dividing in the bag, so there is no problem.
I would like to
also understand if it is a hard cataract which has less epinucleus protection. Are those cases where you would not want to do in the bag, like Dr. Deepak had said, hypermature cataract, of course, but even a cataract with less epinucleus, would you want to do it in the bag?
No. Very hard cataracts you should not try.
Yes.
No, I would like to ask Dr. MSR. I think he does all the cases. Any cases you take, he does he fractures it. Sir, would you like to?
Yes, Dr. Ramcha.
Yeah, this is I call it as phacosuction, and phacofracture is a nice terminology for that. Phacosuction is not invented by me. It's an American doctor who invented it. Had, it had the award, one of the best 10 ophthalmic surgeries. That's the award that was given to it. I modified Wool's technique. So the only one thing I would like to add is, as Dr. Amulya Sahu mentioned, I continuously inject viscoelastic in front of the nucleus with a 25 gauge cannula. That's the commercially available. I used to make it 26 earlier. Now I switched over to 25. Most of the cataracts can be bisected with just the shaft of the cannula itself. You don't need a tip or whatever it is. If it is not bisectable, then I use the cystitome that's already on the table to do it. But cystitome is again infusing visco continuously in front of it. Now the question came, which is the best visco that's conducive for the for this technique. I wouldn't say cohesive viscos are good at it, because cohesive visco do not protect the endothelium as much as dispersive visco, and cohesive visco will come out. It is an open chamber technique. Cohesive visco basically has not much place. It has place in specific issues, but not much place in an open chamber technique like SICS. It comes out the moment you go inside. It's visco is out. So I would personally prefer either a chondroitin sulfate, which is a dispersive, or HPMC, which is affordable and excellent dispersive. And that's the one which you should be injecting through cannula in front of the nucleus to separate moving nucleus from the endothelium.
Yeah.
Yes. Thank you very much. Shall we, any other questions, Satyajit, or shall we go on to our next speaker?
Yeah.
Yeah.
And we can go on to the next speaker.
Yeah. So our next speaker is Dr. PNR Subudhi, again, a very prolific surgeon and national figure, and who has been doing a lot towards safety and the security for the ophthalmic surgeon of today. And he is the director of Ruby Eye Hospital, Behrampur, Odisha. And he is going to tell us again something very important. There are moments when we have to move on from phaco to SICS, and when and how to convert is going to be his pearls. On to you, doctor.
Thank you, Dr. Chitra. Am I audible?
Yes.
Am I visible also?
Yes.
Yes.
Thank you, sir. Thank you, Dr. Chitra, to give an opportunity to speak in front of stalwarts like Dr. Abulya Sahu, Dr. Devasis, and Dr. MSR.
Sir, you can make it full screen, please.
It's full screen.
It's not full screen. No, sir.
Can others mute themselves because we are hearing too much of background noise? Can you go full
I
screen?
made it full
Dr.
screen.
Subudhi? No, you are not full screen. You have to go to that icon to make it full screen. Yes, yes. No, you're not. Mr. Shari, can you mute everybody?
Sir, click slideshow. Slideshow, click slideshow.
Yeah, I know. Is it right? Hello?
Not yet, sir, not yet.
Not happening, though you did click on the slideshow now. One is to again stop sharing and share again, but you've already done that too. Maybe you will have to just click side by side. Yeah. Try once.
Deepak can rescue us.
Yes, Dr. Deepak, you could guide him.
Yeah.
Now you're done. Now you're done.
Now it's okay?
It's okay.
Thank you. Thank you. Thank you, Dr. Satyajit, Dr. Chitra. And also I thank Dr. Chitra to make me jump from last to the middle. As you know, tomorrow we are organizing the East Zone Conference at Puri. I invite all of you to join us at Puri. So this is a very beautiful topic has been assigned to me. You know, whatever maybe you are surgeon, whether you're a phaco surgeon or a SICS surgeon, but you must have a mastery on SICS. Because here I'm seeing all the surgeons, they're doing phaco and they are doing SICS also. So at one point of time, definitely the phaco surgeons have to change the technique to SICS to save them from a disaster and save the patient's vision. Next. Okay. So is it changing?
Yes, it's changing.
So when to convert? Yes, there are so many points I would say, but out of all the most important point, the posterior capsular tear. So improper case selection, intraoperative meiosis, corneal edema, wound-related problems, excess use of phaco and liquid fluids, and CCC-related problem, and last but not the least, the posterior capsular tear. So any of these cases, sometimes we need to convert ourselves from phaco to SICS. So basically, I would say that there are three indications. One, the posterior capsular rupture during the surgery or general dehiscence noticed during the surgery with or without a dropped nucleus. When the nuclear fragment is larger than half the size of the cataract, it's better to convert. Errant capsular axis in the intumescent cataract. The intumescent cataract is very common in our country. Sometimes you have to convert yourself. And of course, unexpectedly dense cataract, which you have not planned earlier. So while doing phaco emulsification, notice that it's better to convert yourself to prevent the corneal damage. So how to make this transition? So whenever conversion from phaco to SICS is warranted, it's important first to ensure that the antechamber is well maintained with a good visco, and so that the hypotony is not there. Next, any nuclear pieces there in the bag should be brought into the antechamber over the iris, because once you enlarge the incision, it's very difficult to bring the nuclear piece to the above the iris, because the pressure gantry will not support it. So steps how to go there for this conversion. If you are doing the temporal side, abandon the temporal side, go to the superior side, and if it's under topical, give a subtenon block. And of course, if you are doing a superior side, you will continue the surgery going a little bit behind your corneal incision and construct the tunnel. Again, you see whether there is vitreous is there or not in the antechamber. If the vitreous is prolapsed, perform anterivitrectomy either to the anterior root or pars plana, but it is better to do a pars plana vitrectomy. So, because it will pull the vitreous back into the posterior segment, so that you can reduce the extension of this posterior capsule, that general distance. So you can see better to put the trocar and cannula and do the vitrectomy through the posterior root. Then of course IOL fixation. You see, inspect and see if the capsule rupture is very small, you can still continue with the surgery with the your whatever the IOL you have planned. But if the capsule is incomplete, but there's a large posterior capsular tear, better you go for the 3-piece IOL, which is placed to the sulcus. And if the capsular bag is not salvageable, it will come out. So better to remove it, and you can plan it whether it will go for a primary fixation or can secondary fixation, either scleral fixated IOL or AC IOL. So we have seen many AC IOLs till date, maybe after 20 years, 30 years, they're doing very good, excellent vision, having a 6/9 vision till date. So small video. This is the errant capsular axis. My video is visible?
Yes, yes.
Okay. You can see just it has gone a little bit very. We try to retrieve and complete the axis. And at another point, no doubt you could complete in the lower part, but still the errant capsule axis you try to retrieve, but we fail. So already it extended to the periphery, so it's better to convert here, because continuing the surgery may land in trouble of vitreous disturbance. So we gave a subtenon, and we little bit behind, we went behind and created a tunnel. There should not be any hesitation to convert yourself, because of interest of the patient.
I'm good. 500 का समोसा 500 कुछ बचेगा मेरे पास नहीं है, दो हमको.
Satyajit, mute yourself.
Sorry, man.
Again, single piece IOL is placed in the capsular bag, and you could complete the surgery without any complications post-operatively. Yes, one more video. No. It's not going. It's a hard nucleus, grade 4 nucleus. No doubt we planned for the PECO. PECO is going very smoothly. Little bit iris prolapse is also there. Surgery is by Praveen. I have to confess. So as you notice, there is a small postcapsule tear. We abandoned the surgery, then we converted it to the PECO, SICS, and we could complete the surgery without any complications. The 3-piece IOL is placed. You can see the central piece here. So to summarize, however, whatever phaco surgeon you are, so definitely you have a scope for doing learning SICS. At the time of crisis, you have to convert yourself and do a good Rexis and good SICS to save yourself from the great disaster. So phaco is revolutionary in the modern day cataract surgery, no doubt, but still it's essential to be familiar with the manual SICS. There are certain cases, situations like small pupils, weaker journals, hard cataracts, and poorer endothelial function all make the procedure more difficult for cataract surgeons, and timely conversion SICS will decrease patient woes and misery. Haripriya et al. And Venkatesh et al. From Arvind Eye Care have shown the safety limits are significantly higher with MSICS compared to the phaco emulsification in these cataract cases and also among the trainees. So thank you very much for giving the opportunity to speak about this technique in front of you.
Thank you, Dr. Subudhi. They were wonderfully depicting videos, bringing home some very important points for converting to PCR. I have a question which I would want Dr. Debashish, Dr. Saurabh, anyone to take. When you are converting from phaco to SICS, would you suggest that you go to a superior plane from temporal, or temporally go on a posterior plane and do, or would you advise a posterior scleral cut being made on the temporal incision? What would you advise? Would you advise even increasing the temporal CCI, or it does not make sense at all?
No, enlarging the phaco incision is makes no sense at all.
Yes.
So definitely, I mean, we need to take a fresh incision, and it is very important, Chitra, that we fill the globe tightly, and because the scleral incision, the sclerocorneal tunnel dissections, all would require a very tight globe for a good dissection. And obviously, Dr. Subudhi has made the point very clear that where does SICS really help in converting from a difficult situation in phaco, where you have a PCR and there are big fragments which are hard left in the eye. So whether you are doing whether you are using a lens as a IOL as a scaffold, even if that be the case, those hard nucleus to emulsify in the anterior chamber may not be a good idea. A lesser trauma could well be easily done to the eye by enlarging the incision, by giving a regular SICS incision, getting the fragments out, and then proceeding with the surgery with vitrectomy. And
would you advise a posterior scleral cut to the temporal incision, or go to a superior scleral plane?
Posterior cut to the temporal incision. I mean, no, I mean, changing the site of incision. I don't think that is necessary, because I think because they are two different incisions altogether. So you can always go below the tunnel, the corneal tunnel of the phaco incision, and develop a separate SICS incision.
Right. Dr. Saurabh, yes, Anaga?
Ma'am, I had a question for the panelists. Like, you have a dense brown or a black cataract, And initially you think you would be able to go ahead and do a phaco. But if you decide to do an SICS, and apart from changing the incision, if you have a rhexis which is not really very big, would you do relaxing cuts in the rhexis so as to be, and enable the nucleus to be wheeled into the anterior chamber? Otherwise, it becomes really difficult, and you can tear actually the
yes,
anterior
Ananga, I
capsule.
mean, that's a very important point raised. And for beginners, I would say that, I mean, doing a second rhexis would be most ideal, but sometimes the pupil comes down in these situations, and probably the visibility is not good. Multiple relaxing incision is the way out. I know you can just don't give only one or two relaxing incisions, because in that case, with the whole nucleus, it can actually cross the equator and disrupt the posterior capsule. So multiple incisions, maybe 6 to 8 in different meridians would be ideal. And you actually preserve the bag. I mean, by giving such incisions, it's not that you don't preserve the integrity of the bag. And second, these are not free tags which you will catch during cortical aspiration.
What would be the way of removal of nucleus delivery if you are caught in a situation with a PCR and you're doing SICS? What would you advise? I want any other expert panel, anybody else to suggest? Dr. Sauram?
Hello, sorry, ma'am, I didn't get the question.
No, I said you have a PCR and you have converted and you're going to doing an SICS. What method of nucleus delivery would you advise?
Yeah, so yeah, in case of these situations where actually the nucleus material is likely to drop in the vitreous, my preferred method is visco expression, because I don't want to take any chances. I will always make a larger scleral tunnel, because here I don't want any resistance for the nucleus to come out. And for visco expression, the technique that I use is that with visco cannula, I go to the deepest point, distal most point under the nucleus fragment, and I start injecting visco from there. The commonest mistake that surgeons do is that they try to form the anterior chamber first, and then they inject the viscoelastic, not from the deepest part, but little proximally, and that may itself push the nucleus down. So once you do that and you have a nice large tunnel, scleral tunnel, I think most of the nucleus pieces come out easily.
Okay. Dr. Deepak, if it was a premium cataract surgery and incidentally SICS has been done, and I'm sure top SICS surgeons would want to do premium IOLs too. But in this kind of scenario, where phaco to SICS conversion, and you have planned a premium surgery, then would you still put a place a premium IOL, or would you go for a monofocal?
In the case of a posterior capsular tear and the rhexis continuity being doubtful, in that situation, I definitely don't think there is a role for any multifocal. So a multi-piece hydrophobic lens in the sulcus would be the best option, with the explanation to the patients. Even in case for torics and all, if the rhexis is compromised, if you compromise the rhexis, then even it's to securing a toric lens also becomes an issue. In those situations, I think best to resort to the other monofocal lenses, multi-piece lenses.
Yes. Dr.
I think I will just add one point. I think Deepak is absolutely right. In such situation, my first aim is to achieve, giving good emetropia for these patients. So at that point, my thought process will be how I can minimize the astigmatism and how I can predict perfect refractive error. So if I am putting in the sulcus, whether I'm going to do optic capture, so I plan. And as rightly said, like when we are doing scleral tunnel, we can also think about the astigmatism. For example, we have planned a toric IOL. Why not use this to correct the astigmatism? So my thought process shifts from the lens rather than giving a perfect emetropia, because that will make patient happier.
Yes, I agree. Shall we go on to our next speaker, because there are a lot of topics and great speakers here we shouldn't miss out. So we would ask Dr. Deepak Meghur is to be our next speaker, and we've already introduced him. So Dr. Deepak, now we look forward to an interesting talk of yours on SICS in lens-induced glaucoma. On to you.
Yeah, I'll be speaking on the phacolytic glaucoma as such, because phacomorphic glaucomas is much more easier, because once we deal with the rhexis part of it, the procedure is almost simpler. But in the case of a phacolytic glaucoma, we're dealing with very pathological anterior capsules, and let us see how we can manage.
I'm Dr. Deepak Megur. In today's case, let's try to find out whether can we save the bag in this eye with extreme zonular weakness. This is an elderly lady who has long-standing hypermature Morgagnian cataract with phacolytic glaucoma. The pressures are controlled and now she's come for surgery. The capsule shows multiple areas of calcific spots. There is mild phacodonosis and the hard Morgagnian small nucleus is settled down, which is surrounded by a pool of liquid cortex. In this case of long-standing hypermature cataract, I expect profound zonular weakness, and the challenge is going to be to deal with these weak zonules and whether we'll be successful in saving the bag. So we need to have some sort of an irrigation to ensure.
So this is a transconjunctival tunnel which I'm doing here. So we're not doing any conjunctival flap. Again, I'll just quickly move on to the rhexis
once
part
the
of
PD
it.
in this parallel to the later to a little bit so that I can pass some zonules are. And we can see multiple folds in the anterior capsule, suggesting, I think, profound zonular weakness in this eye. And immediately the loose cortex comes out. So time to deal with it, irrigate out the loose cortex so that we have good visualization, and then let's plan accordingly. The first thing which I'm going to do is to inject cohesive OAD, that is sodium hyaluronate, into the bag and also in the antechamber. The idea of inflating it into the bag is that it will provide some sort of a stability to the bag, keep it formed, and maybe provide some traction force for us to ease out the rhexis making process. So filling the bag with high molecular weight viscoelastic is probably going to help me. That's what I'm thinking now. So in eyes with loose zonules, capsulorhexis forceps is the best tool to manage the rhexis. So I've gone in with my capsulorhexis forceps, holding the flap and trying to tear it. And the enormous zonular laxity is seen here. Multiple folds are there. Even the tearing is not easy. Somehow I could manage to tear until I go and hit this roadblock, and this is this calcific spot. And this is not looking good here. It is threatening to go into the equator if I proceed further. So I'm just wondering what to do. I just leave it at that, come out, refill the bag with OVD. Let me pause here for a moment and let you know what was going in through my head at that point. Now, I wanted to stabilize the bag before completing the rhexis. I wanted to insert the CTR itself. Or the second option would be to enlarge the rhexis from the other end. So these are the two options which my mind was dwelling into. The first option of inserting the CTR into the bag was a good one because it would really help the bag to get back its stability. The ring would act as an artificial zonule. Then I could complete my rhexis with greater ease and without causing much more damage to the already compromised zonules. But there was one important issue or difficulty with this situation. During the insertion of CTR, this weak zone could give way and extend up to the periphery because the ring could tug at this weak area, and this has a propensity to extend out, and I could lose the rhexis. So that was one issue which really made me think otherwise, and I chose the second option. The second option was just to make a nick at the other side of the capsule opening and then try to extend it. And this is what I'm trying to do it. As I reach this weak area, again, I can't get through this. So using microforceps to the left hand and a micro scissors to the right hand, I'm going to give a small nick and we have an opening here. The rest of the capsule again needs to be trimmed. A tangential cut is given and with very carefully the enlargement of the rhexis is done. So I have some sort of a semblance of a rhexis now. Before prolapsing the nucleus out of the bag, I wanted to enlarge the incision. And as I'm trying to enlarge the scleral tunnel incision, I can see that the inferior part of the bag has really come out. In the sense, the localized zonular dehiscence is very well seen now. The capsular fornix has come anteriorly and folded. So I'm using sodium hyaluronate to fill into the bag and it pushes the fornix back again posteriorly. And now I need to fix this bag before removing the nucleus out. Otherwise, it's more likely that I'm going to lose the bag. That was a challenge here. I push in more cohesive OVD just to keep the bag formed and the chamber also formed. And this is the time for me to insert the CTR. It took a couple of attempts for me to pass the CTR under the entry capsule. Eventually, the ring could be passed into the capsular bag, and important for me to ensure that the ring is rotated and situated in the right plane so that the ring supports the weak area. So I could achieve that. So once the ring gets into the bag, it gives tremendous confidence for us to deal with the nucleus or other steps of the surgery. As I'm trying to mobilize the nucleus out of the bag, we can see that the inferior portion of the bag which is trying to come out looks very stable and it doesn't protrude out, and the nucleus comes out very effortlessly. Using a vectis in the dialer, the nucleus is expressed out using the phaco sandwich technique. There was a moment of scare for me as I'm seeing an oval delineated mark in the posterior capsule. I was wondering whether PC is intact, but thankfully the PC was intact. That ring was in fact an area of calcific zone in the posterior capsule. In front and behind the lens, I can see a few cortex fibers which are check for any prolapse of vitreous through the loose zonules. Thankfully there is none. We can see that the triamcinolone has migrated into the Berger space, suggesting a free access for the fluid from the antechamber to something behind the lens as well. That's it, the case is done, the ports are hydrated, and these are the pictures of the first post-op day. The cornea is fine, very minimal inflammation. This is the incision. Patient had a good vision. Let's look back.
That was it, ma'am. Thank you for the opportunity, and
very nice video.
Wonderful video, very learning video. The basic thing which she told us was that you need to use capsule forceps, most importantly when you are with a phacolytic glaucoma. But when generally about lens-induced glaucomas, when would you think of doing a limited pass planar vitrectomy along with the other medications, general preparation, which you would do in a lens-induced glaucoma? I would want Dr. Ravindra.
Yeah, I think I should congratulate Deepak for a wonderful teaching video, and that's mind-boggling. About lens-induced glaucoma, again, there are so many kinds of presentations, and I wouldn't go and do a pars plana vitrectomy unless it's really warranted, and I would do exactly what Dr. Deepak said: remove the cataract and remove the inflammatory mass, remove the cause for the glaucoma, remove the cause for inflammation. Start treating. I would rather start treating these patients preoperatively with a day or two with steroids as well as NSAIDs along with homotropin, so that inflammation comes down, pressure comes down, then take him up for cataract surgery. Most of them can be salvaged, most of them. See, the weight of the cataract is very heavy. It may be 20-25 grams, I do not know, milligrams, whatever it is, but then weight of the lens is too less. If you have not worsened the zonular compromise during surgery, you can put a lens. Even if it looks scaring before surgery, post-operatively, they are pretty stable. On a long-term basis, whether these lenses will remain in position, I mean, that's the chance you'll have to take in these patients.
Wonderful video, Dr. Deepak. Actually, I wanted to ask you one question. Now, supposing these are cases with long-standing intraocular pressure rise and the cornea is already hazy. So how would you deal with these corneas, like the epithelial edema part of it, the stromal edema part of it?
Usually, what we see is once intravenous mannitol is given preoperatively, the pressure has come to a little bit. And once you do a small paracentesis, many times we are forced to operate even when the pressures are high. So what we have to do is do a very slow decompression. Invariably, once you do a slow decompression, the cornea clears up. Many times there will be pseudo-hypopyon-like picture where the fluid has come out into the antechamber and visibility will be hampered. So just irrigating will clear up the will. Rarely do I require to scrape the epithelium. Rarely. That's a very rare opportunity. Usually I don't require in majority of the cases. Once you decompress the eye slowly and take care of the other factors, the visibility is decent enough.
Dr. Sahu, have you left already? Would you want to add something at this point of time? I think he's not.
Can I add, Madam?
Yes.
Can I?
Yes, Doctor.
Yes, the doubt. See, recently there has been a Morgagni cataract, IOL scaffolding. So there will be a lot of space in the bag because the nucleus is very small and there will be a lot of space in the bag. So I don't have experience. Anybody has experience of putting IOL first, then so that the bag will be stabilized first, then we can take out the.
Yes, that
Mallika, that's usually for phacoemulsification. We do for that phaco part, not for SICS part.
No, it can be done. Not only for because the nucleus will be very small. So the manipulation and would be less. Because, see, you put a viscoelastic and put a bag in IOL inside. So IOL will be fixed there. So bag will not move much. So the very small nucleus, it can be taken out in the antechamber and prolapsed.
Yes.
That is my thought.
Yes, that is, I mean, phaco, we definitely do IOL scaffold with a hypermature cataract. But I suppose SICS, the surgeons here should tell. Any other question? Shall we go on to the next topic? Although I'm sure there is a lot to continue on lens-induced glaucomas itself. Any other?
The next topic.
Yes, Anaga, you want to say?
No, ma'am. I had asked the question. I think Dr. Ravindra sir has answered regarding which they would prefer, phaco trab or SICS trab in case the need arises.
Yes. So
because of the larger incision and more conjunctival involvement. So whether they would prefer a phaco trab or that was what I have.
Yes. So he has mentioned SICS trab. So you can't expect Dr. Ravindra to say anything can be superior to SICS. And he has his own sound reasoning for that. We shall now go on to our next speaker, Dr. Revati, who is the Chief of Cornea Refractive Surgical Services at Arvind Eye Care Systems, Coimbatore. Again, a very versatile, dynamic surgeon. And she is going to tell us about MSICS in pre-existing corneal opacity. So on to you, Dr. Revati.
Thank you, Dr. Chitra. I hope I am visible, my slides.
Yes.
Yeah, thank you very much again for giving me this opportunity of taking part in this wonderful teaching platform, the AIOS ARC series. And of course, I may be a little odd here. I'm going to talk more about the corneal pathologies and of course, doing a cataract surgery in the presence of a corneal pathology. So the corneal pathology, especially, and I can take it as an ocular surface problem. And this can intervene in preoperative planning, intraoperative visibility, postoperative healing also, and also sometimes the disease can get reactivated after the surgery. So in the preoperative planning, many times the question will arise when we come across with a corneal opacity or corneal pathology, which is the main reason for visual loss, and whether we are going to deal it as both together or which one to be dealt with first. And the first two the pictures of the same patient, often you can come across patients like this, many times mistaken for dystrophy because it is bilateral, but these are scars due to old eye king. In very elderly people, you can come across. Surprisingly, for this kind of a cornea, they would have had good vision, reasonably good vision for a long time. And if you probe the history, it will be the visual deterioration is only of recent onset after the cataract. So in these cases, you can just go ahead with do only cataract. Of course, the patient will not have any big difference, but only for the surgeon, it may be a little difficult because of the poor visibility. And of course, SICS is an ideal surgery in such situation. And even in dystrophies, granular dystrophy, many patients may not even aware of it till they come for cataract surgery. We can just go ahead and do cataract. But if it is a macular, very rarely they come to the level of cataract before undergoing a keratoplasty. But in case of endothelial dystrophies, the whole thing is different. Of course, we prefer to do either mostly both together. And also long-standing opacities, we have to keep amblyopia in mind. And accordingly, we have to give promises to the patient during cataract surgery. And pterygium is another one which can interfere with induce astigmatism. So it can interfere with IOL power calculation. And also sometimes if it is massive and bilateral double pterygium, interfere with the entry location and compromise visibility. So again, the often asked question, what to do, whether it can be done together or at a different time. My take is always one at a time. And if it is an immature cataract, I would like to re-establish the ocular surface properly and also reduce and stabilize the induced astigmatism and then do a proper IOL power calculation and go ahead. And if patient's preference is mainly to regain vision, and if it is a mature cataract, I would go ahead with only cataract surgery. And why I say that is because of this. Just removing the pterygium alone is an obsolete procedure. Often you will end up with the complications like this. And that too in the presence of a large wound which is entering into the globe. This is not at all a preferable logical conclusion. So naturally you would like to, you have to do a conjunctival autograft in the presence of another big ocular surface trauma in the presence of an intraocular wound. So it's better to go to stabilize the ocular surface first and then go for the pterygium surgery or the cataract surgery later if it is needed. Then the IOL power calculation can be also challenged by the irregular astigmatism caused by the corneal pathologies like scars or ectasia. Often PMD will be associated in this age group. And not only that, even the corrective surgery like correctoplasty can result in irregular astigmatism often because of the, especially PKP, because of its irregular wound healing. So then it may be quite challenging to calculate the IOL power. There are many methods, but still you have to keep in mind the refractive surprises will be there. And if the astigmatism is regular like this, maybe we can plan our incision as Dr. Ravindra and others pointed out. But still that even I too feel that even including the limbal relaxing incisions often can lead on to regression over the years, and later again the astigmatism can reoccur. And the corneal degenerations or any, especially the superficial ones like BSK or the CDK, you can go for either PTK or the superficial keratectomy to make the visibility more as well as to make the surface more smoother. If usually with the BCL, it can heal very well, but sometimes a very large and thin cornea, you may need an amniotic membrane. Allow the normal epithelial healing and then go for plan this cataract surgery. And here the adherent glaucoma, I would like to warn, if it is in the periphery, not in the center, just go ahead with the cataract surgery alone. And very most importantly, do not touch the adherent iris to the scar, and because this invariably can lead on to a large descemetorexis, descemet's membrane detachment and compromised cornea. It's better not to disturb it at all. And often you will come across with poor pupillary dilatation in these cases. So in case if it is a soft cataract like this, you can just go ahead and, as others pointed out, you can go ahead and do the surgery. But if it is a dense cataract or a nuclear sclerotic cataract, you may need something like some kind of a technique to enlarge the pupil, as the surgeon here, Dr. Jebin, tried use the hooks to enlarge the pupil till at least the capsulorhexis, and later before removing the prolapsing the nucleus, he just removed the hooks so that they will not interfere in that step, and then go ahead with the normal surgery. Again, you can see this adherent glaucoma here. The cornea is quite thin. The scar is quite thin. You can see the iris pigment behind. So touching this to release the iris and trying to regain the anterior chamber is not at all a good idea. Just leave it in that position only. So coming to viral keratitis, if you know it is a HSV keratitis, then you have to take some precaution. The surgical stress as well as the post-op steroid is going to reactivate the condition. So go for oral antiviral prophylaxis. Start it at least 2 weeks before and continue as long as you are going to use steroid. And even if there is a scar which you are not sure HSV, but if you are in doubt, it's either better to start it or closely observe the patient. But subepithelial keratitis like this kind of opacities in a post-adenoviral, it doesn't need any prophylaxis. Often the post-op steroid is going to clear the condition also. And some of the other ocular surface problems like MGD, which often will be associated with cataract patients, you have to treat it first, because the main problem, if you don't treat it first, you may end up with a tunnel infection. So it's better to treat it properly, take it seriously, and then go ahead with the cataract surgery. And atopic periocular allergic dermatitis also is something to be warned of. These patients are often associated with the cell-mediated immunity, defective cell-mediated immunity, and they are more prone for infections, especially fungal infections. So it's better to get a dermatology clearance as well as continue their treatment and then go for cataract surgery. Coming to the dry eye, again, it's a commonly associated condition. If it is a non-immune mediated, of course, only the problem is wound healing may be problematic, persistent epithelial defect can occur. And of course, ocular flora might be altered. So go for a conjunctival culture before surgery, and also use plenty of lubricants and temporary punctal occlusion. All those steps you can take and go ahead with the surgery. But if it is a immune mediated, you have to keep in mind it can trigger the post-operative sins and other problems. So you have to get rheumatologist clearance and also continue the immune modulation throughout your surgery and in the post-operative period. And the same thing holds good for conditions like PUK or scleritis. And even in a quiet PUK like this, because of the compromised ocular corneal structure, your entry wound will be a challenge here. Sometimes you may need to restore the integrity, and then you have to go for surgical intervention. Again, you have to continue the immunosuppression, and because they are in immunosuppression, perioperative, even systemic antibiotic coverage may be advisable. And this is another patient post-thermal injury, probably because according to the history, who landed up in our camp. And again, this is quite difficult. Only a nasal small part of cornea, 1/3 of the cornea was clear. The surgeon was sitting on the nasal side and going ahead with the surgery. We didn't have time to go for any ocular surface reconstructive procedures here. So that is somehow you may end up with like that. And other cicatricial conjunctival problems like post-Steven-Johnson or OCP, the main thing is reduce the inflammation, restore with surgical intervention graft, and do not touch the cornea in conjunctiva in these cases. So go for a clear corneal section or take minimal injury to the conjunctiva. A non-healing epidefect sometimes you can come across in a post-operative period, and maybe due to diabetes or missed out ABMD, then you have to use plenty of lubricants and epithelium-friendly drugs. In these cases, you have to plan even before. SLK is superior limbic corrective conjunctivitis is one condition where MICS is ideal, especially the superior approach, because this itself will heal this conjunctival callosis, which is a localized one, and it will give a lot of relief to the patient also. So in conclusion, any active ocular surface or corneal problem has to be controlled, and diligent preoperative workup and planning is important. And reactivation of a chronic pathology is also to be kept in mind, and it has to be planned. A prophylactic, whatever measure has to be taken, in these cases. Thank you.
Wonderful presentation, Dr. Revati. I mean, so beautifully depicted with a lot of teaching videos. Hats off to you. So I'll ask you one first question before we go on to the expert panel. When you're doing a combined triple surgery, what are the pros and cons for doing SICS against phaco in these corneal procedures?
Triple means you mean if it is a PKP, yeah, if it is a PKP, there is no question that wound itself is enough to do the cataract surgery also. But the tips are like here, the chamber is open. So the whole thing will be like reverse. It will be convex. Your rexes, your aspiration of cortex, everything should be done in a convex manner, because the bag will not be, the posterior capsular bag will not be in a concave manner. So that you have to keep in mind and proceed when doing this. And if it is EK, then of course we can do in any way, like if it is DSEC, we can use it as a SICS, or if it is a DMEC, we can go for, depends on, I decide it only on the condition of the lens and the nucleus.
Yes. Question to the expert panel. If it is a case of a microcornea and you are doing an SICS and you end up making a smaller sclerocorneal tunnel, but you have a dense cataract, what are the challenges in nuclear delivery, and what would you want to tell us on that? Anybody on the expert panel? Dr. Saurabh, you would like to add anything here?
Yeah, I think those are tough cases even for SICS because the anterior segment is much smaller than the size of the nucleus. So I think in such cases, we have to be prepared for even posterior approach sometimes because it depends on the size of the cornea. Of course, if it is big, 8 millimeter and bigger, you can do regular SICS. Even phaco I would prefer rather than SICS in such cases because since the nucleus is very big and anterior chamber is very small, I'm not experienced with phaco fracture. Maybe Ravindra sir can answer about that more, but I would prefer phaco. And if it is very small cornea, then I would even sometimes go for a posterior approach.
Dr. Debashish?
Yeah, I think what Saurav said, the only thing that has to be kept in mind that here we have a surprisingly very big nucleus, because so that we need to keep in mind. So the rhexis has to be adequate, incisions have to be adequate, phaco fracture techniques. I prefer the snare technique, but yes, I mean, I would prefer phacoemulsification over SICS, given the small nature of the anterior segment.
Yes.
Not only that, many times they will be associated with iris coloboma and lens coloboma like that.
Yes. So you are challenged by the zonular weakness also in some of these eyes. How would you, what is your cutoff in a microcornea for an IOL, Dr. Revati? Or nowadays we have customized IOLs?
No, I have not much experience with the customized IOLs. Generally, the normal regular IOLs only. As Dr. Bhattacharya mentioned, the lens as such will be of normal size, usually in these cases. So only the anterior part will be smaller.
Yes. Yes. Any other question, Dr. Satyajit Anagha?
Yeah.
Shall we?
Revati ma'am, is there? Okay, go ahead, Saurabh. Go ahead, Saurabh.
Yeah, Revati ma'am, thanks a lot. So such a excellent presentation and teaching. I wanted to ask because we commonly give topical NSAIDs post cataract surgery. With the corneal, these problems, ocular surface disorders, how do you put the post-op regimen? Because I think NSAIDs should be avoided. So how do you use steroids for longer period, or you change some other medicines that you use along with that?
Yeah, as I said, generally in these cases, I would prefer, if it is an antibiotic, I would prefer a chloramphenicol based one or a ofloxacin based one. These two are more epithelial friendly drugs. And steroids, of course, in such cases, of course, you can go for dexamethasone combination rather than prednisolone. And of course, steroids, it depends. It need not be always longer time. But if it is an ocular surface inflammatory condition, better to use it before and quieten the thing. And always in this case, I would prefer to do a conjunctival culture. I don't know. There are many, I mean, it is controversial whether it is really useful or not, but I'm sure these cases, the ocular normal flora will be altered. So it's better to go for a culture and then plan your surgery.
And lot of lubrication also along with
Yes, lot of lubrication, preservative-free lubrication. Yes, of course.
Revati ma'am, I had a question. Boliye, Devashish sir, boliye.
No. I just wanted Dr. Revati's lecture was so good, so comprehensive. I really want to thank ma'am for the same. And
thank you, sir.
Just to highlight, that the acyclovir point that she made. I mean, she even said that even if a scar doesn't look a typical HSK scar, to be on the safer side, because the reactivation of these disease after cataract surgery is a big problem. So, I mean, start it a week before and at least continue it 2 months or till you are giving topical steroids, at least for 3 months. And so, I mean, these points are very important and less talked about.
Yes, very true.
Yes.
Yes, your question.
Dr. Chitra, I have a small question for Dr. Revati. Dr. Revati, you said persistently that any adherent glaucoma should not be separated from the iris, should not be separated from the cornea. But if it is circumscribed, if it is just attached there, let it be vascularized leucoma. I have a tendency to, I have urgent. I always do. I fill it up with viscoelastic so that it's in traction, and I take vanas, long blade vanas, and cut it off. And even vascularized adherent leucomas, I've had no problem. The bleeding is not continuous; it stops in no time. But of course, you showed a case where the iris is gone into the cornea. Even in such cases, I just try to trim the iris around so that at least we have a normalized anterior chamber at the end of surgery. So what are your comments? Why did you?
Yes, sir. Sir, maybe with your experience, as he said, don't try to release it. You can cut it, and there will be a surgical coloboma there. You can cut it and leave it. That is okay, but that should be planned. For beginners, generally, what I used to do that. We have the tendency, okay, we are doing a surgery, we'll try to reform the anterior chamber. So we'll try to release it. That's a wrong move. But you can cut, and that is the elegant way so that the adherent part will not be affected at all. So
I agree that it should not be
part
pulled.
only will be cut.
It should not be pulled from the cornea. I fully agree with that. But come very close to the cornea. Don't touch the decimates. You raised a very nice point that it can tear off the decimates. But if you put the attachment on stretch by deepening the chamber there, take a long blade, go very close to the cornea and trim it up. That's what I do. And even people enlarges there, and it will facilitate your cataract surgery for a paracentral opacities.
But another important question Anaga has to you, Dr. Revati, about topical cyclosporine drops. Would you consider using them long term in these corneal-based procedures? Cost of it is a deterrent.
Yeah, if it is an associated ocular surface problem, yes. Yes. I think Dr. Sinha wanted to ask
your question.
Dr. Divya wanted to comment. You are muted, Dr. Divya.
Yes, sir. So my question for Revati Madam is, how do you calculate IOL powers, Madam, for compromised corneas? Do you follow anything in particular? One is to look at the other eye for the approximate, especially when we're doing a PK with cataracts.
As I said, for some time we were following the OBSCAN method, where we do the OBSCAN and see whether it is a regular astigmatism and just go ahead and do. Even you can go for even toric IOL in such cases. But otherwise, what was described by Dr. Carlos, you can go and calculate the mean power, posterior mean power, total mean power, and total optical power, and take that as a K1 and K2 and calculate and all. But the problem is the newer OBSCAN machines, they don't have that facility at all. Only the old one, OBSCAN 2, I think we can do that. I think that machine is almost obsolete now. So that method is, I don't think it is of use. But even in Pentacam, there are some ways, something similar to that has been talked in the Keracon. But I don't know about that. Somebody talked about it in Keracon, some similar method.
Okay, Revati ma'am, very nice presentation. Since we are talking about advanced gadgets, in these compromised corneas, especially when we are doing SICS, is there any role of specular microscopy, especially because you are bringing out the nucleus very close to the endothelium and the corneas are compromised? Is there any role of specular microscopy before doing such cases?
Yeah, but if it is some Gate or something ways we can do. But if it is a scarred cornea, it's very difficult to get. But of course, post PKP or post keratoplastic cases, yes, specular we have to do. And whatever be the specular, of course, we are going to use only cohesive or preferably a combination of both.
Thank you. We have 4 more speakers, so we would go on to our next speaker. I'm sure there's a lot more to learn. And of course, hats off to you, Revati, for a wonderful presentation. Our next speaker is...
I'll go for a...
I think she's not heard. Am I heard now?
We can hear you.
Yeah, so we shall now go on to Dr. Ravindra's presentation, and he's going to be talking to us on premium IOL and MS-ICS. On to you, Doctor.
Am I visible on my
Yes,
slides?
yes, slides.
Fine. I'll give a very small slide presentation. Uh, Basically, an ideal IOL in cataract surgery should give good vision in all distances. That's ideal. Go back to natural way in which the eye was built without any complications or compromises. Profession versus industry. Industry wants to call all small advancements as like a negative aspherical, blue blocker. They're all, premium IOLs, but actually multifocals, accommodating lenses, and torics. These are the only three lenses which take you back into the normalcy. So it can be one of these four. We're all very familiar, but I would like to add that with modern designs, all these complications are very, very less. And I offer one of these lenses to everybody who has a need for them. And as recently as 2016, a survey said that 43% of cataracts.
Sir, your slides are not moving.
Okay, how about now?
No,
and they are not even full screen.
Sir, you have to stop sharing, then share again the slideshow. The PPT has been shared, so not the slideshow.
Okay, I'll go to the video. I don't know how to. Is that visible now?
Yes, sir.
Fine. So what I was trying to say is that only trifocals, bifocals, EDOFs, and continuous range of vision lenses and toric lenses are to be considered as premium lenses. All others are not. So let me save some time by showing a video. This is how I do a premium implantation. That's a steep axis. I'm sitting on the upper temporal quadrant. Maybe I've actually measured it where exactly I have to go. The initial entry is about half or even 1 millimeter away from the limbus through intact conjunctiva. And I go a little fast. I go through it. It's a 2.8 millimeter blade. It's a little longer incision when compared to a phaco standard, but it's very important to see that the configuration should be rectangular. It should not be smile or frown either in the anterior end or posterior end. The next is injection of viscoelastic into the anterior chamber. This is done under topical anesthesia. Here is the most important part, to keep the chamber deep. It may not be important here, but in a very complex case, it's extremely important. I entered the chamber with a cystotome itself by perforating the floor at the limbus. Then I'll do a rhexis of adequate size. And then I missed this point. Okay, now I enlarge it with a blunt blade. Again, you see that the lines anterior and posterior should be absolutely parallel to each other. Next will be enlargement of the anterior end. This is a recent thing. About 1 year ago, I started this because converting from this scleral incision to this incision, I had little more loss of endothelial cells, and that I discovered that it's because of tight anterior end. And after making enlargement, my the loss of endothelial cells is least, just like what I used to get at this thing. A good single point hydrodissection. Go a little fast. You're all familiar with this. And bisect the nucleus as it was shown by Dr. Mallikarjun and remove each piece. And it's, as you can see, it's a low pressure technique. The pressure is not increased. Patient has an IFIS. It's very floppy iris. You can see the pupil is constricting. And this is an irrigation aspiration Simcoe cannula. Both irrigation and aspiration are controlled by me so that I can control the depth of it. Subincisional cortex is aspirated by right and left Simcoe cannulas. And now you can, now I slit the anterior end of the cartridge so that there is no disturbance to the lens at all when you are implanting it. This is an Indian IOL, Indian multifocal IOLs, which are as good, or I would rather say they can be better than imported ones, because these are designed, the ring size and spacing is designed for a smaller pupil when compared to any imported lens. And this has given excellent results to me. And these are available both in CRV and multifocal and bifocal. Trifocal is my second priority, only for those people who have a need for that distance. If they don't have a need for distance, I do not want to divide them into a third area which is of no use to a person who is not using laptop or monitor. I would rather use a bifocal lens in such patients. Even in a mature cataract like this, it's very easy. You can do a rhexis. It's a closed eye. I've stopped it halfway between to decompress the capsular bag. Now I'm enlarging and continuing it with the rhexis forceps. remove it, bisect it, and take it out of the eye. And then you can put, even in such cases, it's important to include the lens thickness and AC depth in your calculation so that you have got on the spot, the results, especially mature cataract. It takes a lot of biometry efforts to get, because you can't do a optical biometry, you have to do an immersion biometry. And it's giving very consistent results to me, even in such patients, to put a multifocal lens. So you go and put a multifocal lens, and that will be the end of surgery. Rhexis is, of course, irregular. This is a case of posterior subcapsular cataract. My approach to posterior subcapsular cataract is a little different because it's a low pressure technique and a low flow technique. I'll just start with the next one. Yeah, that's a posterior subcapsular cataract, threatening to be a posterior capsular cataract. I've done a Rhexis. I do rotate the nucleus, epinucleus mass. It's a capsular separating hydrodissection. This step is very important to save the posterior capsule, and there's no lateral movements of the nucleus, epinucleus mass at all. It's brought into the anterior chamber, so the posterior capsule is not involved in the surgery at all, neither the zonules. Though it looked transparent and soft, it's a very hard nucleus. Needed a couple of strokes with the 25 gauge cannula, and so you can see the capsule is open there. If I pressurize the chamber now at this point of time, it's going to balloon backwards. All the pressure is going to go and hit there, and the capsule could break. So here in a low pressure technique where the AC is not deepened, it's normal depth, and the fluidics is very, very low, you can go and remove the cortical aspiration. Cortical aspiration is very easy because you've done a hydrodissection even in this patient, and then you go and put a multifocal lens. So my first priority lens today is a multifocal lens. I've implanted, usually I match the right eye and left eyes. Very rarely I have matched, multifocal lens in one eye, the bifocal lens in one eye, and the CRV lens in the other eye. But we'll try to buy from the same company instead of changing.
Sir, 1 minute remaining.
Fine. So that's the end of surgery. The eye does not need bandaging. The amount of astigmatism this tunnel produces is about 0.5 to 0.75, depends upon where I've entered it. This is pretty common. It should be straight. If when you're enlarging it, if the tunnel comes backwards at the edges, then you will have a lot of astigmatism. You'll have to modulate the tunnel in such a way that there is no cutting backwards at the ends of the tunnel. It should be straight, and the outside one also is straight. And this astigmatism can be very well controlled, and we do specular microscopic studies in every eye before surgery and after surgery a month later. And if there is a change, if there is a drop in specular, we know that what exactly is causing it, and that's one good reason to get a feedback continuously about your surgeries. Thank you.
Thank you very much, Dr. Ravindra. Amazing videos as usual. But seeing by your video, you're not going to answer the question. You have to answer these questions more relevant to a young surgeon. Now, how does this young surgeon decide to move into a premium IOL segment with the SICS wound, its variability and the possibility of it being put on a stretch, especially in hard cataracts? What would your tip be for them?
Yeah, a very good question, Dr. Chitra. Amazingly, wonderful program. What I would recommend is consider every lens that you put as a premium lens.
Yes.
Target emmetropia in every case. Do everything that's possible to work up these patients preoperatively. As I said, excellent biometry has to be done either by you or by somebody else. Don't indent cornea when you're doing in a mature cataract. You'll have to depend upon immersion biometry. So that's pretty accurate. And then look at the wave of A and look at the K reading. K reading is very difficult in a mature cataract. So you'll have to trust the other eye and ask the patient to move the eye with a bright light pointing in the other eye, so that he can move and bring the cornea to the center and take a K reading, not once, but twice, maybe even thrice by different people. So once you have the fixed K readings and axial length, then it's very easy. Analyze the results. You put same brand, don't change your brands. So take one brand, and wherever multifocal is available, take the monofocal platform in the same company and keep doing it. And one of the most critical thing that you should do is you have to match the surgery with the post-operative results, SIA. SIA is the most important thing in a premium lens, and you should have a good control. Either you keep the SIA. I can create a zero SIA in this surgery by modulating the, the surgery, though the incision is as big as 5 or 6 millimeter. That's a possibility. And the other surgical skills has to be very good. So amount of trauma that you induce into the eye should be minimum, and you should target for a very clear cornea on the first post-op day. Cornea has to be clear on slit lamp. There should not be any striae, folds, edema. Maybe at the tunnel side, you'll have, at the tunnel bottom itself, you'll have some edema, but rest of the cornea, especially central cornea, has to be pristine. And then you analyze your results, at least 20-25 results. You know your astigmatism, you know your corneal level, you know your biometry. These are the three most important things. Then you're ready to implant your multifocal lenses.
But then the challenge in a hard cataract, unless you're doing a nuclear practice technique, is you have to increase the size of the rexis. Okay. And when we are talking of a premium IOL and size being very critical here, I suppose in those situations, all of them have to do a nuclear practice only.
Nuclear bisection within the capsular bag is a viability, but it's hazardous to the zonules if you are a beginner. Yes. It has to be prolapsed out through a 6 millimeter tunnel or through an 6 millimeter capsular rexis, or with an oval capsular rexis. So it's a possibility. So you can have a 5 millimeter by 8 millimeter or 7 millimeter capsular rexis. Through that, any nucleus can come outside. You design the ovalness in such a way that the haptics are inserted at a place where the diameter of the rexis is smaller. So this is one tip that I can give in such patients where you need to put a multifocal lens or a toric lens in a case. Toric lens, it's ideal to have a circular rexis. If it's oval rexis, it will rotate. So
before we go on to the next speaker, the last question I would ask you is, when would you not do premium IOL and you're doing SICS? Has any contraindication?
Whenever the macula is off, we do an OCT in every case. We do endothelial count in every case. Wherever there is an endothelial problem, or if K is not, we do a pentacam in these patients preoperatively. If it's an asymmetric astigmatism, macular diseases, corneal decompensations, and very tough surgeries, where you expect that there'll be more turbidity or turbulence in the surgery, we would not put a multifocal lens.
Thank you. Thank you very much, Dr. Ravindra. I think you answered all the questions. We shall now go on to our next eminent speaker, Dr. Paneerselvam, who's director of the Arasan Eye Hospital, E-Road. And I'm sure all of us know the kind of surgical training he has given over the years, and the kind of community service he's been doing is extremely laudable. And I'm sure he's very experienced to tell us about MSICS in a black cataract. On to you, Dr. Paneerselvam.
Thank you, Dr. Chitra. Thanks for the wonderful opportunity and excellent program that you have organized. So I'm going to talk about SICS in black cataract. So what are the challenges in
You haven't shared.
Hello?
You have to share your presentation.
I'm sorry.
Wait. You have to go to share screen.
Okay.
You have to open your presentation before and then go to, you want to be the next speaker? You want to do that?
No, I'll do it.
Okay. Yes. Go to slide. Yes, excellent. You've done it.
Oh, sorry. So the challenges in black cataract. What are the challenges? The nucleus is big. The zonules are very fragile, and there is always usually an associated pseudoexfoliation. So how to manage such case by doing SICS? First is wound construction. The wound construction is a bigger incision, and there should be adequate scleral pockets. The most important slide
is not moving, sir.
No, I'll do that.
Yes.
This is the incision we make. So routinely, a frown incision, a bigger size, more than 7.5. You should be liberal in your.
Sir, the PPT is not.
We can't see your slides.
Can't see.
It's fixed on the first slide only, sir.
Sorry.
We can only see your first slide, credits.
No, now you go back to slideshow.
Yeah.
Go to the next slide. And
yeah. You'll have to click on the slide, sir.
Yeah. Am I visible now?
No, we are not able to see the next slide. Would you try stop sharing and share again and see?
Sir, when you share, you're sharing, not sharing the entire screen, you're sharing the application. So you can try sharing the entire screen, sir. It should work. Yes, sir. Just try again. Yeah,
Yes.
now
Yeah.
it's showing, sir.
Yes.
Yeah. A
Yes.
bigger incision, the regular frown of 7.5 mm in size or more than that. You should be liberal in your incision. And it should be, the tunnel making should be proper and go through that and then concentrate on the making a scleral pocket, adequate scleral pocket. Both sides. And moving from the cornea to the scleral side, you can avoid the buttonholing. Now make for the side port, put Trifan loop. Now enter. This is very important. Too advanced to make high astigmatism. Too near proximal, you will have fish mouthing. The entry should be, you should always cut while opening. This is the important thing. Next is, this is another important, very interesting approach by Dr. Pradeep Mohanta. He has a double SICS. He makes two SICS wound joining at the one tip. So it makes for a bigger opening. And it also facilitates suturing at the end. So regular tunnel, open up. So a big opening is, tunnel is made, enter as a regular one. And then after putting a lens in, you can always suture and make it tight. This is a very interesting one. So next is the capsule management. The rexis has to be large and really large. And if you are not able to make larger rexis, you should always opt for a relaxing cut or even a can opener if you are not very sure about your rexis. Always have the pupil as the marker and go along with the pupil so you will not miss it. And fixing the globe with the left hand and then making a rexis is always easier and approachable. And make small, gentle hydrodissection. We should not force because of the big volumes. So now the nucleus prolapse. This is where a problem comes from. Many of the young surgeons. There should not be any stress on the zonules. It's always better we have two hooks applied, one above and one below, and then dial out the nucleus. This is very important. You always go underneath, inject viscoelastic, take two hooks, one below, hold it, and the other one rotate, dial it out of the bag. Now is the nucleus delivery. This is where the comes. Once the nucleus comes into the bag, out of the bag and into the anterior chamber, what we have to consider is is this size and the incision size match? Whether this nucleus will come out of the incision that I have made. Most of the problem comes with the incision nucleus mismatch. So if you find the incision smaller, you should not hesitate to extend the incision. Then the technique comes. Either you can use the irrigating vectors if you are well versed, or you can go for a sandwich technique. The irrigating vectors go underneath, push, and then maintain the pressure and bring out the nucleus. Very well it will come. Yeah. The other thing is sandwich technique. Here the incision is very long. Only catch here is you should, because of the visibility problem, you should not catch the iris. So always in the middle, you pull out as one unit. So this is another way of doing. Then IOL implantation. Here is catchword is very gently. Go, be careful with your cortical aspiration. Look out the fluid flow. It should not be very fast, and put an appropriate lens, either PMMA or a 3-piece or even foldable, depending on the capsular support that we have. So this is how a black cataract is made. And if the wound is tight, the stromal hydration is made. Check whether the wound is watertight, then there is no need for any suture. You can close it as it is. So black cataract managing is not different. Only thing you have to refine the steps. The incision has to be big. The rexis has to be larger. The prolapse have to be gentle. You should ensure a very safe delivery out of the eye. And the cortex aspiration must be careful and do an implant and very appropriate IOL. So this is how we are managed. The only thing is, if you are a regular surgeon, what you have to consider is the patient. If you are a regular surgeon, the ego comes in, whether I can manage. It should not be a point whether I can manage, whether this is helpful for the patient in my hand. If it is not, SICS is a very good technique for managing a very hard cataract. Thank you very much.
That was a brilliant presentation, Dr. Paneerselvam. Such important take-home points like the need for a large incision and the different options of incisions which you showed were all excellent, and of course making a larger rexis. But the question which I would have is, what would be the technique? You would do a large incision. You have shown two ways of making your incision. What would be the way to go? I would ask Dr. Debashish and Dr. Patwardhan.
Chitra. Yeah, I mean, yeah, the incision for a big nucleus has to be adequate, be it at the capsular level, the rexis has to be big. At the incision level, there are 3 levels of incision. One is the internal incision, which is so the corneal valve has to be dissected as far down to 3 o'clock and 9 o'clock. So the internal incision is big enough. And then the incision might get stuck in the scleral pockets. So, I mean, in the tunnel itself. So we must have adequate scleral pocketing. So we must remember that the incision, these hard cataracts are not only big in size or in length, it is thicker also. So, you know, you need that thickness in the tunnel. So the scleral pockets are important. And of course, as Dr. Paneerselvam said, that you need an external incision, which should be adequate and big enough. I would prefer a Frown incision. And the only objection to a straight incision here, because you cannot continue a straight incision big enough. So, you know, Frown you can still enlarge further if you have any limitations of the external incision. And in case there is any disproportion, which Dr. Selvam mentioned, and you get stuck at any point, don't pull up the nucleus, because, you know, it is an automatic reactionary thing that we pull up the nucleus. Let us understand one basic fundamental thing of the SICS incision, that when we lift the upper incision, the incision closes. When you press the posterior lip, the incision opens. So all you do is just press the posterior lip, take out the instrument with which you are taking out the nucleus, push the nucleus in, and then correct the incision at whichever plane the disproportion is, and then proceed a second time. So that's it.
Dr. Ravindra, would the kind of black cataracts Dr. Paneerselvam showed, would you still consider doing a premium IOL on these patients?
Yeah, why
Yes,
not?
why not? Yes, certainly.
Bisect it and do it.
I will not even have a backup lens. I'm sure that we can put a multifocal lens in this patient, provided your biometry is good. You need to enter AC depth and lens thickness in your biometric calculations. Otherwise, you'll go hayway.
Yeah, but your Rexis has to be larger.
Rexis has to be large.
Yes. So anything else anybody would want to ask Satyajit, Anagha, before we go on to our next speaker?
I have a question.
Go to the next speaker, ma'am.
No, yes, Dr. Ravindra, what
One
question?
small question. And
Yes.
his videos were just superb, just superb. And I just wanted to know how he irrigates when he takes it out. I've never used irrigating wire vectors. Any tips for using irrigating vectors and the type of irrigating vectors that is showed?
Yeah, irrigating vectors, you have to go in with fluid, and then with the pressure you have to build up. It's only with practice you have to take it. But in a doubtful case, I feel the sandwich is much better than irrigating vectors in these cases.
One question is, when you go inside and irrigate it, will not the the lens goes up and sticks there? Like the pressure is from behind the lens. So how do you maintain the space between the endothelium and the moving lens?
Now already the lens will be floating within the viscoelastic. That is the only thing, and usually it doesn't cause that much of a problem. Only here that cases the nucleus molded itself into the tunnel and came out. Otherwise, if it is open, it will come out.
Do you have any, Debashish, you can answer this. Is there any calculation possible to assess the size of the nucleus and then customize the tunnel? So you sometimes, you expect a large nucleus and you make a big tunnel and you end up, looking at a small nucleus which easily comes out. Is there any tips as to how do you match the nuclear size versus nuclear thickness versus the tunnel size?
I always find when I inject viscoelastic, if there is iris is floating, comes up, then I feel incision size is not enough. Then I extend. It's better to extend rather than minimize. So I always start with 7.5, inject viscoelastic, and then before taking out the nucleus, if the iris comes out, the space is not enough, I extend it and then.
Yes. One question is, earlier when we were doing ECC, I used to use Maloney's keratoscope, to titrate the incision. I mean, any one of you use keratoscope to, titrate the tightness so that you end up with least amount of
MS, to answer two of your points. One was the irrigating vectors. Now, irrigating vectors, you can connect it to the drip, or you can use a syringe and continuously keep on irrigating. Now, all that you are doing is, you are taking the eye down and then you are irrigating, not pressing on the posterior lip. Okay. Now, you take the eye up and, align the nucleus with the incision. And now you are only depressing the posterior lip. The irrigation is continuing. I mean, like you keep on injecting viscoelastic in your cannula while you are bisecting to stay away from the endothelium. So, with the irrigation, the iris or the nucleus floating up, touching the endothelium, or the iris being pushed down is not a possibility. Okay. The second question is, if you have made a 7 or 8 millimeter incision, in the post-op period, it is only the central portion. If your incision doesn't slip in front, then the astigmatic factors, if the incision is scarring in this meridian, that will be neutralized by the scarring on the other meridian. So Essentially, it is the central 3-4 millimeters which is astigmatically matters. So it's not, it is the coaptation of the wound, I think, or the entire incision which matters.
Thank you very much. We shall now go on to our next speaker, Dr. Tamilarasi, and she's a senior consultant at the Eye Foundation Group of Hospital based in Coimbatore. She's not just an amazingly graceful, versatile surgeon, but she's an excellent surgical trainer. And I think all our postgraduates and all the fellows coming in learn a lot from her, and we go to her, grateful to her. So she is going to tell us something more interesting. I don't know why she was quiet through the session, but she is one girl with a lot of very intelligent thought process. So she is going to tell us about SICS and pseudo exfoliation. On to you, Tamil.
Good evening all. Thank you, ma'am, for your kind words. Today, in the next few minutes, I'm going to share my experience in managing pseudo exfoliation cataract. Pseudo exfoliation cataract can present in very different ways. So we should have a set of guidelines and the necessary instrumentation to deal with meiosis, varying degrees of nuclear hardness, and every degree of zonular weakness. A thorough pre-op evaluation is very crucial. Subtle phacodonosis is best appreciated in an undilated pupil. This is intumescent cataract, pseudo exfoliation, small pupil, and shallow anterior chamber. The anterior chamber is very shallow, and the patient also had a gross phacodonosis. So this shallowness could be attributed to two factors. One is the intumescent nature of the cataract, and second, a gross zonular weakness. So the patient is apprised of the nature of cataract and the guarded visual prognosis, the alternate procedures, and the IOL needed. Assessing the anterior chamber depth is crucial in these eyes. Any asymmetry in the anterior chamber could indicate a zonular weakness. And extremes of anterior chamber depth in an eye with an emmetropic axial length should caution us. This is a case with pseudo exfoliation with gross phacodonosis. Such gross phacodonosis, eyes with such gross phacodonosis, we should examine the patient in a supine position because the nucleus could fall back so posteriorly, which could be difficult for an anterior segment surgeon to access. So we might need the help of a VR surgeon in such cases. So preoperative pearls is thorough pre-op assessment with respect to corneal endothelium, anterior chamber depth, pupillary diameter, nuclear grade, degree of nuclear density, and the zonular weakness. As I said, mild phacodonosis is best observed in an undilated pupil. Examining the anterior chamber depth is really important, and patients should be apprised of the nature of cataract and need for the alternate IOL. And it is advisable not to delay surgery in eyes with pseudo exfoliation. Intraoperative pearls, it's going to be a repetition of what my mentor and teacher Dr. Panniselvam sir said, and I'm going to re-emphasize these factors. Adequate size tunnel is really important because this is the first gateway to let the cataract out. I make a temporal sclerocorneal tunnel, usually straight, and I ensure that my side pockets are adequate to deliver the cataract. The next gateway is making sure our pupil size is adequate. Experienced surgeon can work with small pupils, but in case of associated comorbidities like PXF and hard cataract, it is better to expand the pupil. I'm using a stretch pupilloplasty using 2 Kuglans hooks so that I could expand my pupil to additional 2 millimeter, which will give me the way to perform the rhexis of adequate size. We can use iris hooks also. Third important step is ensuring capsular rhexis is adequate. Subtle phacodonosis is appreciated first while doing rhexis. Dr. Deepak Mehur has excellently demonstrated the capsular wrinkles which could be seen. The first case is an intumescent cataract where I started my rhexis small and I spiraled it around to an adequate size. The second case is a hard cataract with PXF. The pupil is around 5.5 millimeter. I stop in between, inject viscoelastic and retract the iris to see the tearing point so that I make a rhexis of adequate size. We could also do an envelope capsulotomy. This is a PXF case with a hypermature cataract where I made a linear cut using a kerato and extended on either side using the Vanna scissor. And once the flap is created, the rhexis is done as usual using a capsulorhexis forceps. This ensures the rhexis is of adequate size, and never err on a smaller rhexis in a pseudo exfoliation case, which is going to put further stress on the zonules in the subsequent maneuvers. Many surgeons would disagree doing a hydrodissection in a total cataract, but I prefer to do a multi-quadrant gentle hydrodissection. This ensures that the nucleus is mobile and also helps us to prolapse the nucleus using this hydrodissection. And hydroprolapse is the safest way, which puts least stress on the zonules. If I'm going to use a manual way of delivering the nucleus, as Dr. Panniselvam sir said, this is a bimanual technique of nucleus prolapse. Once one pole is lifted, the second instrument, which I normally use as a spatula, I place it under the equator of the prolapsed pole. So this acts as a fulcrum, and this prevents the stress being transmitted to the zonules. So the nucleus can be easily prolapsed using this technique into the anterior chamber. Before ensuring the nucleus delivery, we should keep in mind that the pseudo-exfoliation cases can have endothelial count less. So ensure that our tunnel is of adequate depth and use a dispersive viscoelastic to protect the corneal endothelium and do the nucleus delivery. In a case of uncomplicated case of PXF, I don't alter the choice of the implant. Here I'm using a 6 mm rigid PMMA IOL in the bag. And usually single piece foldable IOL can be preferred for gentle unfolding, and 3-piece IOL because of the rigid haptics which reinforces the zonules. And some cases will require haptic in sulcus with optic capture, which decreases the chance for pseudophacodonosis. We should understand that PXF is a progressive zonulopathy. In addition to the zonular weakness the patient is having preoperatively, we might induce with our technique intraoperatively, and this zonulopathy is going to progress in the postoperative period. And capsular tension ring will help only in mild case of zonulopathy, which is evident as ovalization of a previously round rexus. And we should remember that this is not going to prevent late bag IOL complex subluxation or dislocation. So CTR is not indicated in uncomplicated PXF case, and depending upon the degree of zonulopathy and the patient's age and life expectancy, we should decide whether we are going to use a CTR with CTS or a modified CTR, CONE CTR, to secure the sclera so that the IOL bag complex is going to be stable throughout the period. In case where there is a gross zonular weakness, it is better to plan an alternate IOL. It depends upon the surgeon's comfort and experience. I prefer doing an iris clip IOL, and this is a case with gross phacodonosis where I plan an intracapsular cataract extraction and then an iris clip IOL. After the nucleus is being delivered, a thorough anterior vitrectomy is done, and then the iris clip IOL is enclaved to the mid-peripheral iris, and this prevents the ovalization of the pupil. Once it is done in a planned atraumatic way, the inflammation is going to be less and the chance of post-op CME is also less. This is a post-operative picture where the patient had a BCV of 6/15, improving to 6/7.5 with -1 sedative. So intraoperative pearls is never work through small pupil, which could lead to a small rexus and complicate the whole procedure. Hydroprolapse or bimanual technique of nucleus prolapse is zonular friendly and ensure endothelial protection throughout the procedure. Postoperative follow-up, control inflammation and look for spikes in the IOP. And capsular phimosis should be looked for, the risk factors being a smaller rexus in presence of a zonular weakness where the intact epithelial cells on the anterior lens capsule, remnant capsule, cause the phimosis. So polishing of the ALC rim is one way to prevent it, and making a larger rexus also helps. And in case we find the capsular phimosis, it's better to do the ND-YAG laxin capsulotomy once it is identified. This is going to prevent further phimosis. Thank you for patient listening.
Thanks, Tamil. That was a wonderful talk, and the questions got answered. So one is, all of us need to remember that hydroprolapse would be least traumatic to the capsule in an eye with pseudo-exfoliation. I would want to ask Dr. Saurabh a question here. I understand he's back. So as Tamil had said, different options in an eye, fold of CTR, of course, in not indicated in an early pseudo-exfoliation. But would you think of putting a 3-piece IOL in the sulcus with optic capture when, Dr. Saurabh?
Yeah, I think the IOL trap technique, which Dr. Deepak had shown in his videos, where we put the CTR to fix the bag and then put a 3-piece IOL so that the haptics lie in the sulcus, while optic we can get it captured in the bag. So the bag has double support in the sense. So that is a good technique if we can get away without any significant zonular damage during the procedure. So I think that is a good option to have.
And the opinion of the all the expert panel, what would be your approach when you want to do when you deal with an intracapsular inadequate capsular support? Would it be a iris clip now, or would you want to do an SFIO? I would want one word answer from all the experts who are here. When would you opt for each, maybe?
You said capsular support's not adequate. So yes, I mean, scleral SFIL is our choice.
Okay.
But I think iris claw is excellent. I learned from Dr. Ravindra sir's videos, and he has, I think, tremendous experience for over years. I think I would like to hear from him about the iris claw.
Yes.
Yeah, you see, initially I started with scleral fixation lenses long time ago, decades ago. I used to suture it there, but many years later there will be necrosis, suture cuts off, and I had issues, surgical issues. Then once I switched over to anterior chamber lenses. I've implanted a lot of them. They're very good. AC Kelman lenses are excellent. But only thing is, implant them horizontally, implant them convex anteriorly, so that endothelium doesn't, so that it doesn't erode and cause pain. If you implant it vertically, the lid action itself will press the loops against probably the ciliary body area, and it's all, the pain remains for a long time. I always implanted. Iris claw lenses are right now are for last maybe 10 years. They are my preferred way of handling these cases, and I've stopped doing scleral fixation lenses for various reasons. I'm very comfortable with them. It's very quick surgery, and I don't have to bandage the eye. Patient goes home seeing, and not much talking with the patient. I just tell them there was a complication, and I have put an alternative lens, and they start seeing just like PC lenses.
Yes, 100%. Yes.
So that's my preferred technique right now.
As Dr. Ravni is not there, I'm going to just take some questions related to your talk because it's sort of incomplete. So her talk was on small pupil challenges. So for the attendees, I want you all to tell me, like, if you are going to use iris hooks, at what time would you remove these iris hooks after doing the rexes and hydro? When would you remove the iris hook before the nucleus prolapse naturally? Dr. Saurabh?
Yeah, so generally, I think many experienced surgeons, they can get away even without using iris hooks in small pupil. But what I get from the young surgeons who are training with us is that they have a lot of problems if we don't use the iris retractors. So till the capsulorhexis and the prolapse of the nucleus, we keep them. And then the superior ones, we remove them just before the nucleus delivery. And afterwards, again, we can put it back if they have trouble in doing the cortex aspiration. So that's the technique that we follow.
And if you have a scarred conjunctiva following a VR surgery, how would you do your SICS tunnel if your SICS is a plan of action?
So I think, yeah, conjunctiva is important, but I think still we can get away if we have done a good, scleral tunnel, and we can always undermine conjunctiva if possible from the posterior part, and then suture the conjunctiva. And nowadays with newer VR surgeries, I think we hardly scar the conjunctiva. So thankfully it's less.
Should not be a problem. But do you all feel that the small rexes in the phaco surgeries are probably the reason why you see more late in the bag dislocations, bag with IOL dislocations as compared to the earlier surgeries? Or those cases were also happening then with larger rexes? It was just that it was not sort of commented upon?
I think you are talking about the pseudo exfoliation case.
Pseudo exfoliation case.
I think nowadays people are, living longer. So maybe probably they were not living that long after surgeries previously. And either phaco or SICS, I think we commonly see this subluxation after 10 years. That's my experience. So for that matter, I think scleral fixation or iris claw may give longer results, but of course, PCIL is much safer in the way for the endothelium and maybe less inflammation chances as compared to iris claw and scleral fixation. But of course, after 10 years, there might be if the patient leaves that much, then there may be a chance that we have to refix the IOL.
And I think we should err to make it a larger axis in all pseudo-exfoliative cataracts.
Yes, I think Dr. Tamil Rasi rightly mentioned about that.
Yeah.
Madam,
So
can I make a small...
Yes, doctor.
Regarding iris hooks in small people in SICS, since last 2 years, I stopped using iris hooks. I'm using pupil expansion devices.
Rings.
So I'm using I want to tell, but it's Gupta ring. That is what I'm using it, and it doesn't come out. I mean, when you're maneuvering in the antechamber or removing the nucleus, it stays there only. And also putting and removing is also easy. And even before starting, I had that mindset. So whether should I, whether it will stay there or whether it will come out with a nucleus and all. But I have not tried with a B-hex expander. But Gupta Rang is
yeah, with BHEX it doesn't work because one thing, it's very small.
Yeah.
So and it's very flimsy. So even with phaco putting IOL, like plate haptic IOL, it's a big problem because it goes in or comes out. So but Gupta ring I have not tried. I think it's worth trying that for the size.
So any other questions before we conclude? Because I think we have fairly covered most of the very relevant issues with SICS. So I think I would come to my concluding remarks. I think it goes without saying that yet again, we've had an amazing webinar, and this could have happened only because of the expert panel and their fantastic contributions and the great set of speakers. I mean, one to beat the other. It is just amazing the kind of videos which we saw today. And thank you one and all of you for your wonderful contributions. And of course, my thanks are always due to my co-moderator and my ARC team who are always there with me. I think thanks are very much due to our AIOS admin, Kripal and his team, who are always there sending those SMSs to you all the day before and on an hour before the surgery. And also for the webinar, our thanks are due to Sai and Manjula from Numerotech. I'm sure they ensure that I manage to invade your inboxes as often as I do. And thanks a lot to them. Our thanks are again very much due to Dr. Anand Sethi and his team. You can see how meticulously these webinars happen week after week and ends right on time. And they do it so nicely. And my thanks, my deep felt thanks to Entod for their amazing sponsorship. I remember talking to them just at the beginning of my ARC post, but they've just been there constantly supporting all my ventures. And thank you so much. And of course, finally, I think you owe our thanks to attendees. Their attendance, which is always informed to me after the webinars, have always been greatly encouraging. And of course, the viewership which occurs over the weeks and months. So thank you, one and all. Thanks a lot for this amazing webinar. Thank you. Thank you, Doctor.
Thank you, Chitra.
Thank you for the opportunity, madam. Thank you.
Thank you.
Thanks, Dr. Chitra.
Thank you.
Thank you very much. Thank you. Till we meet again.
Dr. Chitra, how many people watch these webinars? You've been so active, and
yes.
How do you spend so much of time on these webinars?
Thank you so much.
In spite of your very busy schedule.
No. Actually, earlier and all, it used to be 1,800, 2,000 and all that. But now after the COVID has become less, it easily from 600, 700, 600 for those rarer topics, 700, 800 for the other relevant ones.
Very good, excellent.
But would you believe it? Over the weeks and the months, the viewership goes to 8,000, 9,000 and all that.
Oof.
So, like people later sit when they have time, they go back and view it on the YouTube and all. So, these are like something like a huge library of learning. All these wonderful things you people talk. I'm sure everybody would, when they need it, they can go back and watch these.
Which was your most popular?
Will you believe it? Shall I tell you?
Yes.
Every single webinar, when I finish, when I close the laptop and I turn to my husband and tell him this was the best webinar since I've done. He has actually got bored of hearing it because that's how the quality is. The ophthalmologists of our country are so good that it is truly, truly amazing. Wonderful.